A very good afternoon, everyone. On behalf of entire W4C organization committee, I welcome you to second day of World Conference on COVID and Critical Care. We are honored to have esteemed faculty and speakers on board today with us. With this, let us begin our first session for today, that is a debate on long-term anticoagulation needed in all hospitalized patients. To chair this session, I welcome Dr. Vinay Singhal, Additional Director and HOD Department of Critical Care, Fortis Hospital, Ludhiana. Teacher for DNB, IDCCM, Publications in International and National Journals, part of ISA, NTF for COVID-19, and special interest in mechanical ventilation and quality issues in critical care. I request our chairperson to now introduce the speakers for and against the motion.
Good morning good morning, everyone. I'd like to welcome you all for this debate on long-term anticoagulation is needed in all COVID hospitalized patients. Or not. So we have two experts for this today. Expert who is going to speak in pro for the topic is Dr. YP Singh, is the Director of Critical Care at Max Super Specialty Hospital, and our next expert is Dr. Pradeep Rangappa. Is going to speak against the same topic, and he's the consultant critical care at Columbia Asia Referral Hospital, Bangalore, and he's past accreditation secretary, Indian College of Critical Care Medicine, secretary ISCCM, Bangalore chapter, past ISCCM South Zone member, and he had revived a critical care associate. So can we start this?
Good morning, everyone. We are going to have a debate on the topic today, that is a long-term anticoagulation in all COVID hospitalized patients. And we have our eminent speakers, Dr. YP Singh, Dr. Pradeep Rangappa, and we are going to see how we are going to have some results, some new information, new data from next 20-25 minutes or so. So we all know that the incidence incidence of thromboembolism was high during this COVID-19, and it was a global concern. The thrombogenic potential of this COVID virus, we all know, was very, very high, and it was hypothesized to originate from its ability to produce an exaggerated inflammatory response. The anticoagulants have been used constantly and mainstay of the treatment or prevention for the thromboembolism for decades. But however, there is no universal consensus regarding the timing of doses and duration of anticoagulation to be used in the hospitalized patient, especially in COVID-19 patients. So this debate seeks to review the present guidelines, recommendations, contraindications of this anticoagulant uses. For this, I'd like to invite Dr. YP Singh first, and he is going to speak in favor of using a long-term anticoagulation in all COVID patients. Dr. YP Singh, please.
Thank you, Dr. Vinay. So, I'm Dr. YP Singh. I'm a Senior Director and Head of Department of Critical Care Medicine, Max Super Specialty Hospital, Patparganj, Vaishali, Delhi. So today's topic, as Dr. Vinay has mentioned, regarding the long-term anticoagulation in all COVID hospitalized patients. So I am in favor of that anticoagulation. So, as we know that COVID-19 is an immunothromboembolic disease, and there is an overwhelming amount of the literature suggests an increased risk of thromboembolic manifestations associated with COVID-19. There is an increase in the fibrin and fibrin degradation products, fibrinogen and D-dimers, and there is an elevation of these markers have been associated with the worst clinical outcome we already witnessed during the first and second wave. Usage of the anticoagulation in COVID-19 remains an area of the concern. I basically shown in the bold letters. There is no definite guideline published to date highlighting the timing, doses, and duration of the anticoagulation as well as the drug of choice. So whatever we are doing, it's basically an expert opinion, clinical experiences we are sharing and doing, and we using this knowledge for the management of the patients. Most internationally published guidelines based on consensus statements and expert opinion, we are yet to have a definitive guideline in this direction. So guidelines rarely address the requirements of the post-discharge thromboprophylaxis. So this paper, before March 2020, it was the China who had the maximum experience in the COVID-19. And this is the Wuhan virus, we all know. And they were the one who was, the entire world was basically relying on their information, whatever they were providing. So this paper published and was received in a clinical chemical journal in 2020, discussed about the prominent changes in the blood coagulation of the patients with SARS-CoV-2 infection. So D-dimer, FDP, fibrinogen values were found to be significantly high, and antithrombin was found to be significantly lower in the non-survivors, and as well as the D-dimer and FD found to be predictive of the severe disease progression. So all those patients who did not make it during the COVID-19 pandemic or disease, they were the non-survivors who had all these values are very, very high in those patients. So what is the incidence? So incidence is basically divided the patient in two categories. One is the in ICU admitted patient, it was in the tune of 22.7%. And 8% in the non-ICU hospitalized patient who had the risk of the VTE development. But some of the randomized control trial, not the randomized control trial, but this was the cohort studies were being done in France, Dutch, and Italy. They also gave that information that the VT incidence were in the tune of almost in the double digit, 25% in the Dutch study, 22.2% in Italy, and the 16.5% in the French study. So what is the mechanism of the coagulopathy and pathogenesis of the thrombosis in a COVID-19 patient? It has been seen that COVID-19 is not leading into the hypercoagulable state. It is because of it is leading into a hyperinflammatory stage and endothelial injury. So the basic tenets of the three principles of the embolism will be the same, which applies to the COVID-19 patient. That's endothelial injury, stresses of the blood flow, and hypercoagulable state. So what about the anticoagulation COVID-19? What are the current concepts and controversies? And this is a review article published in a postgraduate medical journal in April 2021 from the Indian authors. And they said the parenteral anticoagulations are indicated in any acutely ill hospitalized patients. Low molecular weight heparin, fondaparinux is preferred over unfractionated heparin. And the advantage they said is it's a lesser patient contact of the healthcare staff and no need of the APTT monitoring if you are using them. And out of this LMWH, they said enoxaparin is the most preferred LMWH. What is the dosing of the anticoagulation? If the disease is moderate if I'm saying the patient is coming to the hospital and getting into the and a bed bound. So these almost not all the COVID-19 patients, but all the critically ill patients who are bed bound, at least for 24 hours, they are having a high risk of a VTE complications. And the prophylactic dose is the enoxaparin 40 milligram OD for the 70 kilogram patient where the creatinine clearance is more than 30 ml per minute. For severe or critically ill patients or high-risk patients, means the patients who are on a non-invasive ventilation, invasive ventilation, CPAP or HFNC, the dose goes to the 40 milligram BD for 70 kilogram patients with a creatinine clearance of 30 ml per minute. Now for a diagnosed patient who already diagnosed with the embolic events and highly suspected macrothrombosis, the P or DVT, the dose is enoxaparin 1 milligram per kilogram 12 RD or subcutaneously 1.5 milligram per kilogram once a day. If patient is having a renal compromise or deranged KFTs, then enoxaparin doses has to be reduced, but it is preferred over the LMWH and the fondaparinux. And if your eGFR is less than 15 ml per minute, then unfractionated heparin to be used and advised to be used, and with the monitoring of activated PTT, APTT monitoring. Now, a few words regarding the post-discharge prophylaxis of these patients. And this decision should be individualized, and it varies from patient to patient and their condition. You cannot use a one blanket kind of a advice for all the patients. It depends on person to person. So routine administration of the oral anticoagulants in all patients with COVID-19 at the time of the discharge is not recommended. American College of Physicians, American College of Cardiology guidelines do not elucidate on post-discharge thromboprophylaxis, but NIH guidelines, ISTH guidelines, BTS, British, and the Scottish mention the post-discharge thromboprophylaxis based on the expert opinion, as I mentioned earlier also. And the post-discharge prophylaxis for the your novel oral anticoagulants, rivaroxaban 10 milligram once a day or apixaban 2.5 milligram twice a day. Even in case of the renal insufficiency, warfarin is preferred over the novel oral anticoagulants with INR monitoring. And the maximum period of the or duration for the therapy is maximum up to 45 days, varying between 22 to or 30 to 45 days. So to conclude my point, is a VT secondary to COVID-19 has higher mortality, high incidence of the undiagnosed thromboembolism following the COVID-19. There is an anticoagulation in moderate to severe and critical cases of the COVID-19 is advisable. Enoxaparin is the preferred LMWH in acute phase. Post-discharge prophylaxis may be considered in patient with high risk of thromboembolism event after assessing the bleeding risk. And the rivaroxaban and apixaban are preferred for post-discharge prophylaxis. Thank you very much.
Thanks, Dr. YP. And I feel that yes, you had come up well with the data that yes, we have to use the anticoagulation for a long time in our patients, especially in COVID-19, and this can prevent a certain life. And but again, we'll see what Dr. Pradeep has to say and how is going to say about speak about his points, his point of view. Dr. Pradeep, please.
Yeah. Can I start now?
Continue, boss, please.
I'm audible, right?
Yes.
Yeah, you are audible.
Okay. Thank you. I think my dear friend YP has spoken about anticoagulation as a routine for all the COVID patients. So I beg to differ with regards to long-term anticoagulation, and the point that I would only debate is therapeutic anticoagulation, because that is where the whole debate lies. Whether prophylaxis, I agree with whatever YP has said, that prophylaxis in ICU is a quality indicator. We have no arguments on that. But now the whole debate is whether we anticoagulate, when we means therapeutic anticoagulation, whether we do it in all COVID patients. So for that, I would have a strong opinion of difference. So we need to look into the trials. So I think there are few good landmark trials that have come recently, and this is what has thrown light into what may be the what may be the conclusions that we can derive. So this is a good trial that came in Lancet 2021. So it's called the action trial. So basically the whole understanding is, as YP rightly said, the venous thromboembolism and arterial thrombosis that happens is very much related to DIC and the cytokine storm that happens, and they have a good correlation with high D dimer. And these have been associated with diffuse lung injury, which leads to worse outcome and more severe progression. So we have no doubts about this. And the whole contention is the observational studies prior to this, there were no randomized controlled trials prior. So the observational studies initially showed therapeutic anticoagulation and prophylactic anticoagulation has shown to reduce hospital admission and reduce the intubation. So the whole hypothesis for this came from the postmortem data. So this was this initial autopsy studies which showed a lot of microthrombi formation in the lungs in the autopsy, and they found disruption of the whole capillary network in the alveolar capillaries leading to microthrombi, which leads to worse gas exchange. And our whole understanding is that by giving anticoagulation, we would improve the gas exchange, and that is when we contemplated on anticoagulating. And in fact, the investigators went ahead and saying there is a lot of microthrombi formation with hypoxic vasodilatation, and they even contemplated thrombolysis to reduce the shunt fraction. So this has been the background as to why this whole contention has risen, whether we should therapeutically anticoagulate these patients. So as I said, there are 4 randomized controlled trials. The action trial is the big one, which came in Lancet. So which they compared therapeutic versus prophylactic, and in 31 ICUs, 31 hospitals in Brazil, and these were the inclusion criteria. So here they used 3 types of anticoagulation: rivaroxaban 20 milligram or 15 milligram when creatinine clearance is 30 to 49, and they used enoxaparin 1 mg per kg per day or unfractionated heparin. When they did that, they did monitor anti-10. So they used either of these 3 in their trial, and they did monitor APTT. So what did they look at? They looked at primary outcome as the composite of death, hospitalization, or day 30 needing supplemental oxygen. They looked at it as win-win ratio, and more than one means better outcome in the patient. So that was their primary outcome. Secondary outcome is to look at whether patients develop venous thromboembolism or limb ischemia or acute MI or stroke. So this is a very good study to really indicate to us whether anticoagulation is something that is needed. So 24th June 2020 to 26th February, this study was done. The mean age was 56 and 60% were male. So if you look at the results, the median duration of enoxaparin they gave for 11 days, and 94% of these patients were stable. So when you look at this result, 615 patients, 311 in the therapeutic anticoagulation and 304 in the prophylactic. So if you look at the composite endpoint, which is wins ratio, there was no difference between therapeutic and prophylactic. And in fact, the bleeding was more in therapeutic anticoagulation, and the median duration of first bleed tended to happen much early on in therapeutic anticoagulation, even one patient having IC bleed. And they even looked at secondary outcomes, which is venous thromboembolism or limb ischemia, acute MI. Even there, they did not found any difference. So this was a big trial that came in Lancet as recently as few months back in Lancet, very clearly showing us that therapeutic anticoagulation really does not help in COVID patients in changing the outcome. So these are all the graphical representation of, the red ones is the therapeutic and the blue one is the therapeutic prophylactic anticoagulation. So if you do not subscribe to this, this was another trial which came after this, which is an inspiration randomized controlled trial. Again, this took all the sick patients, as my opponent has said that in sick patients, therapeutic anticoagulation may be helpful. They took 600 sick patients. They looked at composite endpoint of patients going on to needing ECMO, developing venous thromboembolism, and 30-day mortality. And they compared enoxaparin 1 mg per kg versus 40 mg. As you see, there was no difference in the endpoints. And the major bleed, again, there was no difference. And the thrombocytopenia happened more in therapeutic anticoagulation or higher anticoagulation that they were giving. So again, this inspiration trial also did not show any difference in outcome, whether we give therapeutic anticoagulation or prophylactic. So if you do not subscribe to these two trials, this was the most recent that came in NEJM as recent as a few weeks back. Therapeutic anticoagulation with heparin in COVID. So here they looked at primary endpoint, organ support free days. Here they looked at cardiovascular support free days and respiratory support free days at day 21. So this was a very big study, 1,098 patients, 534 in the therapeutic and 564 in the prophylactic. They looked at median organ support free days. As you see, there was no statistically difference between therapeutic and prophylactic anticoagulation. And they looked at survival to hospital discharge. Again, there was no difference between therapeutic anticoagulation and prophylactic anticoagulation. And major bleed, although the signal appeared to be a little more in therapeutic, there was no statistical significance. So again, so the inspiration trial, action trial, and this NEJM, which is a combination of remap, active, and attacked investigators, they took a large set of data, really did not show any difference between therapeutic anticoagulation and prophylactic anticoagulation. And they looked at hospital survival, no difference. Major thrombotic events, there was it appeared to be less, not statistically significant. Major bleed also, there was no statistically difference. And here, interestingly, in this NEJM trial, what they showed was 89% probability of therapeutic anticoagulation led to lower probability of survival to hospital discharge. So this is very interesting, where they said the probability of hospital survival in fact came down, and they said the probability of inferior primary outcome was 95% in therapeutic anticoagulation. This is a very strong statement these authors make in the statistical analysis that in fact the therapeutic anticoagulation may lead to worse outcome. And there was more increase in the alveolar hemorrhage in these patients. So all in all, as you see that inspiration trial, action trial, and this NEJM trial, which came very recently, all show that therapeutic anticoagulation has no role in ICU because they did not show any mortality benefit or any composite benefit, composite outcome benefit, or patients going on to needing ECMO or preventing venous thromboembolism, so on and so forth. So then there are observational studies. This came from US in 2021. Again, all these are very recent. So 64.5% were males. So here they had 6.3% at venous thromboembolism. And the independent predictors of this were male patients and increased D-dimer. Here again, this is an observational study where therapeutic anticoagulation was used in 384 patients out of 2,809. And the risk of death, as you see, hazard ratio is 1.12 and confidence interval is not significant. Again, here in observational study also, it did not show any benefit. So the summary of my talk is routine therapeutic anticoagulation in ICU. If you see the action trial, inspiration trial, and the NEJM trial and the observational studies, they've shown that there is increased risk of bleeding, although some of them may not have been statistically significant. So the risk of bleeding outweighs the benefit, at least when we look at the core evidence. And COVID-19 has shown there is increased resistance to anti-10A levels. So which means to say we have to, that may be the possible reason why many people contemplate on giving higher dose of low molecular weight heparin, assuming its benefit, because inherently there is resistance. I agree therapeutic anticoagulation may have role in very select group of patients where there is already venous thromboembolism which is seen, or there is intravascular devices that are getting clotted, and there is echo evidence of RV strain or pulmonary thromboembolism, or in select group of patients where there is sudden acute deterioration in respiratory status with increased fibrinogen and increased D-dimer. So these are very select group of patients where I agree with my opponent that there may be a role for therapeutic, but the debate is routine anticoagulation for all hospitalized patients, which is the topic of the debate. That I beg to differ because there is no role, at least from the evidence. So I end with this beautiful quote that according to Charles Bukowski, sadness is caused by intelligence. The more we understand certain things, the more we wish we didn't understand them. So thank you all. I'll talk about the rebuttal.
Thanks, Dr. Pradeep. And very nicely presented, and especially this recent trial, this remap cap trial, and it shows that yes, this anticoagulation may not have a positive effect on the outcomes. But again, I'd like to invite Dr. YP for a rebuttal, and if he has more to say, or what he wants to come up with some in light of this data presented by Pradeep, and please, Dr. YP, please.
Yeah, Dr. Vinay, thank you. So I would like to mention one thing. As I said, it's if you'll go into the pathophysiology of the disease, we understand that there is a thromboembolic events do occur in these patients, subset of patients, and thromboembolic events occur in a tune. As I mentioned, that the French prospective trial cohort study reported that 16.7% of the patients who were already on anticoagulation developed the VTE, 16.7. While the Dutch study, during the same period, they said its incidence was 27%. And your Italian study also said that all these studies said that these patients who developed these incidents of the VTE, they were already on an anticoagulation. So that's very right. Dr. Pradeep has said that definitely, as I mentioned in my second last slide, that it is the patient to patient, you have to vary. There is no blanket kind of a guideline where you have to use the anticoagulation, number one. Number two part, as we all know, and going to the pathophysiological aspect of the COVID-19, it led into that homeostasis changes, and I'm talking that regarding the thromboembolic events. So any patient, these patients who are coming to the ICU, these patients who are bed bound for 24 hours, they are basically high likely chances. As a critically ill patient, leave aside the COVID-19, you need to go in the VT prophylaxis, keeping in that view. Now, coming to all these, the evidence is given by and the trials we discussed about. Maybe need to go into that regarding the long-term use and the non-significant aspect of the bleeding. So non-significant aspect of the bleeding, if they are saying that statistically, so definitely the risk of your severity or the mortality is much higher with the thromboembolic events. So I still looking at the thromboprophylaxis, and the pathophysiology, there is only a 3 modalities so far we used in a first wave and the second wave, and these 3 modality was the oxygen. One is the anticoagulation, and third was your steroid for the anti-inflammatory therapy. So coming back to the point that no doubt bleeding do occur if you are not calibrating the dose, and there is not a fixed rule to calibrate the dose depending on the mild, moderate, and the severe category. You start going with your low dose, starting with the 0.5 milligram per kilogram, for example, and also keeping the watch or your D dimers. This is how you have to monitor and to look into that as well. But even after that, you can have the bleeding, pulmonary hemorrhages, you can have the CNS leak. But thromboprophylaxis or VT or embolic events are more detrimental and more, having the high associated with the high mortality than not doing so. So in my opinion, I will stick to my point that looking into all the aspects, these patients need to be, all the patients to be given. I'm talking not the mild patients who are just managed at a home or other. All those patients who are coming to the hospital and the bed bound, they have to be given an anticoagulation.
Thanks, Dr. YP. So again, REMAP-CAP trial and other trials, what they say, one thing is they are also using they are saying that yes, and Dr. Pradeep also said that we should use anticoagulation. Anticoagulation is important and it has to be used. That is the bottom line. But again, problem is with what doses and what is the duration. So we are having this thing with some difference of opinion on doses and duration, and that is the point of debate today. Dr. Pradeep, please, can you come up with?
I'll just share the slide.
Yeah, sure.
Yeah, so as I said, I agree with my brother YP Singh that there's no debate on prophylactic anticoagulations. All of us are absolutely clear that all sick COVID patients need to be on, for that matter, any sick patients in ICU, they have to be on prophylactic thromboprophylaxis. So here the whole debate is why we said debate, because there are that many trials being done and a lot of resources being put in to find out an answer whether we need therapeutic anticoagulation or long-term anticoagulation in select group of patients. I think that is the point of debate. And for that, right now, because we follow the principles of medicine based on the evidence that evolves, and as I've already said, the evidence that is remaining at this point of time really do not favor the use of therapeutic anticoagulation and long-term anticoagulation for these COVID patients, at least if you have to subscribe to these landmark trials. The reason I say landmark is the Come in Lancet, the Inspiration trial, and the REMAP group. So if we do not subscribe to this, for the benefit of all my good listeners, so this study I have to showcase, which it just came around 3-4 days back in BMJ, British Medical Journal. I don't know, my slides are not moving. Sorry, I'll just redo this. So yeah. Yeah, so this is the most recent trial. It came in October, which is called Rapid Randomized Control Trial. So this possibly puts a nail on the coffin. So this is done, as you see, it's a multicentric, done in Canada, USA, Ireland, UAE, and Brazil. So it is 6 countries they did it. And this study was done between 29th May 2020 to April 2021 across 28 hospitals across these countries, with 465 patients, where they stratified with the patients who had increased D-dimer. So here, increased D-dimer, they took it as more than upper side of the normal levels with saturation less than, which means they were sick patients needing oxygen or more than 2 times the normal. And the primary endpoint, again, in this trial, which just came few days back, they looked at composite of death, intubation, ICU at day 28. Secondary outcome, they looked at whether these patients developed venous thromboembolism. If that is the point of debate, they did look at that as a endpoint, whether your therapeutic anticoagulation has any bearing in preventing this better than prophylactic. See, here you had 465 patients, 228 in therapeutic anticoagulation and 237 in prophylactic, and they looked at primary composite outcome, which is patients needing intubation, mechanical ventilation, death, and there's no difference between therapeutic. So prophylactic is good enough. That is my point of, that is the point I'm trying to drive home here, that we don't need therapeutic anticoagulation. And if the argument is for patients develop less venous thromboembolism if you give therapeutic, here it did show that it did not really show the difference statistically, because as you see, there's no difference between therapeutic and prophylactic about patients developing venous thromboembolism. And major bleed, in fact, if you see, there was absolutely no difference again in this between therapeutic and prophylactic. So, so again, to say that there is, as you see, this evidence that is evolving with huge trials that have come in. So I think these good trials have been good enough to convince us that therapeutic anticoagulation as a routine, I'm marking my words, as a routine for all hospitalized patients is definitely not needed. But there may be this select group of patients, as YP Singh and we possibly both of us would agree upon, where D-dimer C, in fact, D-dimer more than 2 times also, we may not give therapeutic in our practice. Just for the benefit of the audience, let me be very practical what we do. Now, when D-dimers are more than 5 times, definitely we contemplate on thinking of therapeutic anticoagulation, whether if the risk is outweighing the benefit, because the risk outweighs the benefit. But in these trials, one of the criticism is they have taken D-dimers just about more than 2 times the normal, and many of these patients are stable. And for the benefit of all the listeners, in fact, there is another NEJM trial, which I'm sure YP and Vinay would be aware, where they've taken stable patients and they found therapeutic anticoagulation had a benefit actually in that particular trial. And even authors were perplexed as to why it did show benefit in very stable patients. The one I presented was in sick patients, it showed more harm or it did not show benefits. So that is where we have to possibly make some conclusions that as a routine for all hospitalized patients, definitely therapeutic anticoagulation will not have a prophylactic. All of us agree. So that would be my take home from my point of view.
Yes, I also acknowledge the same.
Thanks,
I also acknowledge the same.
Thanks, Dr. YP and Dr. Pradeep. So we are here. We are, all of us are agreeing on to some extent that yes, anticoagulation is important, and therapeutic anticoagulation in as a blanket order in all the patients may not be good for the patient, and prophylactic use of anticoagulants is important. And again, like Dr. Pradeep has said, we have to see that we have to tailor our therapy according to the patient. And if in case patient is having some comorbidities or sickness level is high, or we have to look at the D dimers and all. So we have to tailor made our prescription rather than having a blanket order of having anticoagulation, therapeutic anticoagulation for all our patients. With this, I'd like to close the debate as of now. But again, we are ready to take any questions on this. Good morning.
Good morning. Do we have time for a few questions?
Yes, sir.
So we had gone through the debate, and quick bites from both Dr. YP and Dr. Pradeep. Quick 1 line, 2 lines only, please, sir.
Yeah, first, thank you very much, Dr. Vinay. And very good afternoon, Dr. Pradeep. So my take is, as through this debate, we have already reached to a kind of a consensus. Number one point is that there is no blanket rule to give one prescription which applies to all the complete spectrum of the patient. Number two, that we are very much having the consensus that all those patients who got admitted to the hospital and critically ill, and primarily because we belongs to the intensive care group, so we are dealing with the critically ill patients in ICU. So all those patients who are coming to the ICU, and any patients who's bedbound for 24 hours, the prophylactic anticoagulation is having its place for the VT prevention. Now coming to keeping with the COVID aspect, it's rightly said that 3 modalities, as I mentioned, were the part of a treatment or mainstay of the treatment: oxygen, steroids, and anticoagulation. So anticoagulation decisions and the steroid decision we're taking based on the CRP and the D dimer. So D dimers is not that 2 or 3 times. Definitely, it has to be on the high side. CRP to be on the significant side. Then definitely we were using these anticoagulation in a subset of the patients. But definitely coming to the therapeutic part is definitely to be given in a diagnosed patient, where you have to use the therapeutic doses. But prophylactic, so I'm staying with my same statement which I just mentioned, with the same. I think Dr. Pradeep might add something on that. Thank you.
Yeah. Good morning, YP Bhai and Vinay. So it was a great debate. So we reached a consensus, as YP Bhai said, that prophylactic, yeah, we have absolutely no argument. Any sick COVID in ICU, everyone gets a prophylaxis. But with regards to therapeutic long-term anticoagulation, we do agree that there are select group of patients who may benefit. See, for the benefit of all our listeners, which we discussed after the debate, see, the evidence is really evolving, and the BMJ trial that I presented, I did conceal there was a mortality benefit when they did a subgroup. When they looked at the composite endpoint in that BMJ trial, which is patients needing intubation, mechanical ventilation, patient needing ICU admission, and patients dying. When they took that composite, they did not find the benefit. But when they only looked at the mortality in the BMJ rapid trial, they did find benefit with therapeutic anticoagulation. So that is the truth. And the NEJM trial, same by REMAP, ATTACK, and ACT group, they did 2 studies which came in NEJM. The one I presented was in the sick COVID patients who came to ICU, where it did not show any benefit. But they had another group where they looked only at the very stable patients where they gave therapeutic anticoagulation, and they found a composite endpoint benefit. So that has even perplexed the authors and all the think tank as to why this is happening. So honestly, for listeners, we have no clear recipe at this point of time. So as YPI, we all agree, 2 times D-dimer may be an overkill, but very often in our Indian subgroup of patients, which I have seen in my ICU, which YP agrees, Vinay also possibly agrees, we have found very high D-dimers, up to 10 times, more than 5 times, with worsening gas exchange. And here we have found that therapeutic anticoagulation possibly has benefited. Again, we have to really look at this distinct group. So this evidence is evolving. Right now, we can only agree upon that we have to customize it to our clinical needs in select group of patients where D-dimers are much higher with worsening gas exchange or high fibrinogen, but not as a routine. So that is our take home. But please go through the article of the BMJ. It's very interesting because it did show mortality benefit. So on that note, YP scores again that we may err on giving anticoagulation in these sicker patients with very high D-dimer.
Thanks, Dr. Pradeep. And we all are agree. And again, for this Hep COVID trial, which was published in this JAMA, they also actually they had seen no major bleeding complications in the patients where they had received therapeutic anticoagulation. But one thing is there one consensus is there that we have to individualize the treatment whenever we see a patient, and we have to individualize the treatment. But sometimes it may not be possible in this when we are in the midst of storm. So when there is a pandemic, then we have to put certain blanket guidelines for certain patients. And one thing is very clear, that anticoagulation has to be there, like we use in our ICU. Therapeutic anticoagulation, yes, if possible, we have to get some our patients investigated. So if possible, we can get the coagulation profile of those patients, or we can get the D-dimer, or it should be based on something. We should not blindly start anticoagulation. Otherwise, sometimes we may go into a situation where patients have major bleeds or something. Number two, we have to see that whenever our staff is taking samples from they are very fond of puncturing the femoral arteries. So this can be one of the reasons where arterial thrombosis can be very high if they keep on puncturing these femoral arteries for taking samples and all. So we have to change our culture. We have to look as far as possible. We have to individualize the patient, look for the coagulation parameters, and decide about the long-term or short-term anticoagulation in our admitted patients. I think if everybody agrees on these points, we can conclude our debate. I hope there is no questions from the audience. So we are. Thank you very much. Thanks, Dr. YP and Dr. Pradeep, for a great time and great debate.
Thank you. Thank you, Vinay.
Thank you, Dr. Vinay. Thank you, Dr.
Thank
Pradeep.
you.
Thank you.
Have a great day.
Yeah, thanks.
Over to organizers, please.
you. Good afternoon, everyone. I welcome you all to our first thematic session for the day. To chair this session, I would like to invite Dr. Sanjay Agarwal, MD, Space Director of Eagle Clinic Diabetic Care, Head, Department of Medicine at Ruby Hall Clinic, Pune, Dr. Sanjay Dhanuka, CEO and Consultant Intensivist, Eminent Hospital, Indore, Dr. Vishal Chanbhag, Assistant Professor in Department of Critical Care, Kasturba Medical College, Manipal, Dr. Ziyokov Joshi, HOD and Director Critical Care, Tagore Hospital and Heart Care, Jalandhar. Now I would like to request Dr. Sanjay Agarwal sir to introduce our first speaker.
Good morning, everybody. It's a proud privilege to be part of this meeting. And I would like to introduce Dr. Rajan Barokar, who's going to take our first lecture. And he's going to be speaking to us on comorbidities and COVID-19. Did it affect the mortality? I think this is such an important topic because today we are all battling with COVID. And we need to see how can we prevent immediate and long-term comorbidities. And I'm sure it will be very useful to listen to Dr. Rajan in his deliberation. So the stage is yours, Dr. Rajan. Please go ahead.
Hello. Good morning, everyone. I'll be speaking on comorbidities and COVID-19, whether these comorbidities has really affected our outcome of the patients. How much was the mortality? Which diseases were more common in these COVID-19 patients? And which comorbid conditions affected adversely in patient outcomes? So this is one good paper which I could get through, which was from Canada, and it showed the prevalence of comorbidities among individuals with COVID-19. And it was a review of a literature. Almost 22,000 patients and their cases from major centers of the world were evaluated. And the commonest comorbidities that were seen was hypertension, diabetes, and second to that was cardiovascular disease and COPD. Cancer and CKD being less common. There were few countries wherein the comorbidities were specific, especially the hypertension was quite seen in almost many of the major countries like USA, UK, Italy, China. So mostly around 35% patients were having hypertension and that comorbidity. When it comes to the fatal cases, almost 84% of those who died had one or more of the comorbidities. So when you actually see the non-comorbid and comorbid situations, almost 57 to 60% patients presenting with the COVID-19 infection had a comorbid state, and amongst them, the hypertension, diabetes, as I said earlier, was more common. Similarly, cardiovascular diseases, illnesses was more common in them. Overall fatality was almost 84%. Major comorbid conditions which were fatal was cardiovascular disease, hypertension, diabetes, and comparatively COPD, CKD patients. As has been perceived that patients who had a CKD were probably would not do well in COVID conditions, but however they did well during the COVID period. When it comes to outcome, almost many from all over the world, the places like United States, European Unions, they confirmed that major comorbidities like cardiovascular disease, hypertension, diabetes, they had they seem to have a higher risk than those presented without these conditions in severe COVID-19 complications. The requirement for hospitalization and intensive care admissions was higher in the patients who had a polymorbidity, single comorbid conditions or multiple comorbid conditions like coexisting diabetes and heart disease, diabetes and hypertension, hypertension and heart disease, and the fatality was also very high in these patients. The overall data, it suggested that individuals with chronic underlying illnesses, they probably have a outcome risk tenfold as compared to those who do not have any comorbidities. This is another paper which has nicely shown or evaluated the association of sex, gender, age, and the comorbidities existed on mortality in COVID-19. If we want to see and study the effect of gender and age in these patients, age was definitely those who were more than 50 years had shown a higher mortality. Similarly, when it came to a gender, the patients who, mostly the male patients who had shown a higher events of mortality in this paper or in this observation. So male patients were associated with increased risk of mortality as compared to the females. Patients with more than 50 years were associated with 15-fold increase in risk of mortality as compared to those who were less than 50. Well, these are the common comorbid states. These are the common comorbid states wherein we can see the patients with a kidney disease, cerebrovascular disease, cardiovascular disease had a higher mortality. And surprisingly, in this paper, the patients with a liver disease, they did fairly well while being in COVID. So this would say that implementation of adequate protection and interventions during COVID-19 patients in general, and in particular, the male patients with age more than 50 years having comorbidities may significantly reduce risk of mortality. So probably the adequate protection means staying at home, following hand hygiene recommendations, and avoiding social activities, and interventions like maybe a vaccination, maybe early access to the medical care or health care probably was important in reducing the mortality. Why mortality was high in older males? The male patients have a higher expression of angiotensin converting enzymes which may be related to regulated by male sex hormones, thereby rendering them to more risk of SARS-CoV-2 infections. And that led to a poor clinical outcome also. When we considered age and natural immunity, we are aware that the older people are particularly prone to develop more infections as the natural immunity declines as the age progresses. Compared to younger children, the ACE2 gene expression was significantly high in older children, young adults, and adults which may possibly have a higher morbid conditions. Older people, they are more vulnerable, probably because they have an adverse drug reactions, maybe partly because of either reduced organ functions at old age, and maybe because there are many other multiple drugs which these patients are already on. Similarly, when they are subjected to COVID treatment, and depending on the severity, if the severity is high, these patients are put on steroids, these patients are put on antiviral drugs, these patients are put on anticoagulants, and many of the antibiotics. So naturally, drug-drug interactions were high, the natural immunity being low, and the patients are also on the immunosuppressants. The patients, those who have a comorbid conditions, probably they were more exposed to increased risk of infections, and thereby a mortality was eventually higher in them. So based on this evidence, it was evident that the patients older than 50 years have a higher expression of ACE2 encoded by ACE2 gene, as well as there were other conventional factors like reduced immunity as the age progresses, low organ functions or low organ effects, and coexisting comorbidities. There was a paper which evaluated the use of angiotensin converting enzyme inhibitors as well as angiotensin receptor blockers, their use and risk of infection or severity of mortality in COVID-19. This was a systematic review, and they observed that the use of ACE inhibitors and ARBs in COVID-19 was not associated with higher risk of mortality or severity of infection. So it happened at many places wherein the people have stopped using ACE inhibitors and ARB, listening and hearing about their possible adverse effect in COVID-19 patients. However, subsequently, the ACE inhibitors and ARBs were continued in the patients who needed that or who were already on that. The few physicians or the few intensivists, they suggested use of calcium channel blockers instead of ACE inhibitors. However, in these debating situations, many professional societies, they recommended to continue with the ACE inhibitors and ARBs unless it was contraindicated for some other reason during the COVID infections. Well, there was comorbidities and the difficulties that were seen. The number one was the drugs in COVID-19 and their adverse effects. The drugs like antiviral, the drugs like monoclonal antibodies, drugs like steroids, LMWH, or the low molecular weight heparins, or any other anticoagulants, they already had their own side effect profile. They already had their own drug-drug interactions, and they were also having an immunosuppression there. They were more prone for, these patients were more prone for infections. There were few logistic difficulties while managing these patients in ICU. So especially those patients who were adult, more than 50 years, who were morbidly obese, who had comorbid conditions like diabetes, hypertension. In those patients, anyway, in COVID, during COVID, doing invasive procedures was a challenge. So similarly, providing them with the renal replacement therapy support, that was another challenge. Doing a glucose monitoring more judiciously, maintaining glucose levels to an acceptable levels, avoiding hyperglycemia. This was a difficult task. Putting them on respiratory support like high flow nasal cannula oxygens, NIVs, or an invasive ventilation was again difficult. People have managed that, not that their patients, they didn't come out of it, but managing that in a restricted environment, in an environment wherein everybody were wearing a level 3 PPEs, was really difficult. There were patients who were having a pre-existing immunocompromised states, like patients with arthritis, patients with collagen vascular disease, patients on those who are immune compromised because of retroviral infections, patients with the CKDs. So these patients with the cancer-like illnesses, so those were the challenges which everyone faced. And because of comorbid conditions, the outcome was definitely different in these patients. So those patients with comorbidities would definitely were advised to be extra cautious, and it was better for them to prevent the illness rather than curing that once they acquired a COVID-19 infections. Similarly, the coming of vaccination drive from the onset of this year, in the year 2021, had come as a boon. Definitely, it was pushed very aggressively. Initially, people were having reluctance, but it was pushed aggressively, especially in comorbid patients with the comorbidities. And that has shown the results. The patients now which are coming and presenting with the COVID infections, they are relatively having a lesser severity of infection. They are recovering also. The recovery rate is better in these patients if they are vaccinated enough. And lastly, the aggressive COVID care, once they come into ICU or once they land up in an ICU, the aggressive care and the treatment with the close watch on their comorbidities associated complications was a key to avoid a mortality in these patients. Thank you so much.
Thank you, sir. Now I would like to request Dr. Sanjay Dhanuka sir to introduce our second speaker.
Hello. Uh, our next speaker is going to be Dr. Pramod Sood, and he's going to be speaking to us on ARBs and COVID. The data is quite clear. Dr. Sood is the Associate Professor in Department of Critical Care Medicine at the Dayanand Medical College and Hospital at Ludhiana. We're privileged to listen to him. So over to you, Dr. Sood, for your lecture on ARBs and COVID. Thank you so much.
Good evening, everybody. It would be my great pleasure to be part of this conference on COVID and critical care. I thank the organizing committee, Dr. Narendra Muntar, Dr. Ranveer Tyagi, and Dr. Dittimala for giving this opportunity to be part of this academic feast. I'm speaking on an important topic of the use of angiotensin receptor blockers in the management of the COVID patients. The data is quite clear. I'll go through a brief introduction of the topic, and then would be a brief review of the renin-angiotensin-aldosterone system and the controversies behind the use of ACE inhibitors or ARBs in the management of the COVID patients. And subsequently, I'm going about with the review of literature and finally the take-home message. ACE inhibitors in ARB have been extensively used in cardiac critical care for the management of the patients with heart failures, for the patients with hypertension, and in diabetes, particularly where those patients who are having a diabetic nephropathy. In these cases, it is found to reduces the mortality, it reduces the hospital stay, and reduces the symptoms, and increase the exercise tolerance of these patients. The controversies regarding the use of ACE inhibitors in ARB arises with this interim guidelines that is presented by the CDC with the first first episode of the COVID-19 in way back in 2019, and based on the two assumptions that the angiotensin receptor blockers is ACE2 is primarily responsible for the binding of the COVID viruses onto this ACE2 receptors, and thereby the internalization occurs and infection occurs. And second thing is the long-term use of ACE inhibitors and ARBs is particularly associated with upregulation of the ACE2 receptors. So based on these two assumptions, the CDC has put forward that the use of ACE inhibitors or angiotensin receptor blockers may increase the risk of COVID infections and the severity of COVID-19 cases. As we know that the COVID virus infection occurs by binding, there is the spike proteins that are present on the surface of these of the surface of the coronaviruses, both COVID-1 and COVID-2. It attaches onto the ACE2 receptors present on the vascular endothelium of the kidney, liver, lungs, and also the type 2 nematocytes, after which binding to the ACE receptors, there is internalization, and subsequently with the internalization, the number of ACE receptors are decreased, and hence results in the infection of the target cells. So a brief review of the angiotensin-aldosterone system. The renin in present converts which is secreted from the JG cells of the kidney, converts angiotensinogen 1 to angiotensinogen to angiotensin 1. In presence of a renin, this conversion occurs, and the angiotensin 1 further in presence of angiotensin converting enzyme inhibitors from the lungs is converted into angiotensin 2. Angiotensin 2 is an important molecule in the renin-angiotensin-aldosterone system. It acts on the vascular endothelium, causes a systemic vasoconstriction. Secondly, it acts on the adrenal glands, causes release of aldosterone, which in turn acts on the kidney to cause sodium and water retention. It acts on the thirst, hypothalamus, and increase the thirst in the water intake. It acts on the baroreflex and to increase the blood pressures. It stimulates the pituitary, causes ADH release, which in turn acts on the kidney to cause sodium and water retention. Thus, angiotensin all these actions are mediated through angiotensin 1T receptors. So this is an overview. Finally, the fate of this angiotensin 2 is important. The angiotensin 2 acts via the AT1R receptors. So these are the receptors that is present in type 2 nematocytes and the vascular endothelium of the lungs. And this AT1R receptor has a vasoconstricting action, causes the muscle hypertrophy, fibrosis. It is a pro-inflammatory. It causes proliferation of the cells, and it causes an oxidative stress. So angiotensin 2 acts on AT1 receptors and resulted in extensive destruction of the tissues, leads to the development of ARDS. On the other hand, this angiotensin 2 in presence of the ACE2 receptors is converted into angiotensin 1,7. And this angiotensin 1,7 acts on the MAS receptors, and this causes vasodilatation, vascular protection. It is an antifibrotic, it is an anti-inflammatory, and it stimulates the nitric oxide release. Thus, the angiotensin 2 is converted with the ACE inhibitors into a anti-inflammatory pathway, which is angiotensin 1,7. On the other hand, if the angiotensin 2 is increased with the lack of ACE2, then angiotensin 2 is increased, which leads to what is called as a pro-inflammatory state, leading on to the development of ARDS. So this is an overview of the angiotensin-aldosterone system. AT1R pathway is pro-inflammatory, whereas AT2R and MAS is an anti-inflammatory pathway. The controversies, it is found that those patients with COVID, with age, the cardiovascular disease, diabetic, and hypertension are considered to be associated with increased mortality and morbidity in these set of patients. So thus a causal and effect relationship for the use of why there is increased incidence of poor outcomes in patients with hypertension was being postulated, and it was found that the majority of these patients are on antihypertensive therapies, and this antihypertensive therapy includes the use of ACE inhibitors and ARB, and further with the biological possibility of long-term use of ACE inhibitors and ARB leading on to the development of what is called as the increased ACE2 receptors on the surface. So first, the COVID virus infects the host target tissue by binding to the ACE2 receptors, and by binding to the ACE2 receptors, it decreases the activity of the ACE2, resulting in there is an inhibition of the anti-inflammatory activity. Because of the decreased ACE2 receptors, the angiotensin 2 is not converted into angiotensin 1, and subsequently by the MAS receptor pathway is not followed. As a result of which there is increased angiotensin 2, which acts through AT1R, resulting in increased morbidity and mortality in these set of patients. Second hypothesis is there is an upregulation of the ACE2 receptors in patients who are taking ACE inhibitors or ARB, resulting in, because of the increased expression, there is a good number of ACE2 receptors available to bind to the SARS-CoV-2 viruses, as a result of which that leads to increased infectivity and increasing the severity of the infections, as it has been seen in this slide. Third hypothesis is the use of angiotensin receptor blockers type 1 prevents the pro-inflammatory effect associated with the angiotensin 1 receptor signaling. Therefore, the use of angiotensin receptor blocker may be used as a treatment modality in the patients with ARDS, in patients with COVID. So this is the hypothesis. This action of AT1R is blocked by the angiotensin receptor blockers, as a result of which this pro-inflammatory pathway is taken care of, and hence angiotensin receptor blocker can be used in the management of COVID patients. So, and which is useful. First important is what the literature says about the use of ACE inhibitors or ARB in the incidence of increased infection, whether the use of ACE inhibitors and ARB are associated with the increased risk of COVID infection or not. So this is the three studies. One is by the Marini et al. Published in New England Journal of Medicine. This is a case control study comprising of roughly 6,200 patients, of which 23.9% of the patients was on ACE inhibitors and 22.2% of the patients were on ARBs. And in this study, they found that the odds ratio of developing an infection is 0.96% with the use of ACE inhibitors and 0.95 with the use of ARBs. Thus, and second study in the Veteran Affairs group in New York's Veteran Affairs group, if they analyzed roughly 585 patients were out of 3,789 patients were positive for corona, and the odds ratio was 0.98% of developing a COVID infection in these cases. Subsequently, the null study, which is carried out in New York, also including 12,594 patients, out of it 46.8% were positive. They found that the propensity analysis was carried out, and they found that the propensity analysis was only 0.5. a difference of at least 10% point was pre-specified as a substantial difference. Thus, all the three studies shows that the use of ACE inhibitors and ARB are not associated with increased incidence of COVID infections now. Then, what is the impact of the ACE inhibitors and ARB on the mortality and the severe adverse effects is there? So, these are a meta-analysis that is published in JAMA Cardiology in March 2021, and this comprises of roughly 52 studies were enrolled, and total 545 patients were there. Roughly 26% were on ACE inhibitors and ARB. And the outcome was in those set of patients who are hypertensive and are on ACE inhibitors or ARB, the odds ratio of the relative risk, or the odds ratio is 0.51 for those patients who are on hypertension group as compared to 0.57 in a mixed group. So thus this odds ratio indicates that the use of ACE inhibitors and ARBs are associated with the reduced mortality in these set of patients. So it is important the use of ACE inhibitors and ARB, they are not associated with increase in mortality. In fact, they are associated with the decreased mortality, and there is a trend towards the decreased mortality in these group of patients. Finally, thus the ARBs can be used as a treatment modality in the patients with COVID-19. This was a multi-centered randomized open-label adaptive control trial published in Lancet, carried out at Argentina, where 158 patients were enrolled, 18 in the standard group and 70 in the telmisartan group. It was randomized 1:1, and in the treatment group, a patient received 80 milligram of telmisartan twice a day until the discharge for 14 days or until the time for discharge. And this is a flow diagram, and the endpoint was the level of CRP. As we know that CRP is directly correlated to the poor outcomes, and it is in these set of patients, they found that the level of CRP was decreasing trend, and it persists from day 5 to day 8 after randomization, and is statistically significant. In the telmisartan group, the level of the ACE inhibitors decreases from 9.04 at baseline to 3.83 at day 5 and 2.37 at day 8. And whereas in the standard group, there was a slightly increase in the level of the CRP is there. And the hospital discharge was roughly 79% of the patients were discharged as compared to 56.4% in the control group. Median time to discharge was 9 days in the telmisartan group as compared to 15 days. And the 0.5% of the patient require oxygen therapy in the telmisartan group as compared to 0.93% in the control group. And also they found that the death by day 15, the odds relative risk was 0.30, and at 30 it was 0.19, and ICU admission by day 15 was relative risk was 0.41, and ICU admission by day 30 is 0.41 in the composite endpoint, which includes any of them, whether it is death, ICU admission, or a requirement of the mechanical ventilation, the relative risk at 15 days was 0.44, and the ICU at 30 days it was 0.3. Thus this study gives us an indication that the CRP level is reduced with the use of telmisartan. The death at day 15, death at day 30, and mechanical ventilation requirement at 15 days and 30 days, and composite endpoints are significantly more favored towards the use of telmisartan in these set of patients. So further, the take-home message is the use of angiotensin receptor blockers used in COVID do not increase the incidence of COVID infection. All patients previously using ACE inhibitors or ARB should continue taking them irrespective of the COVID status. If required, discontinuation should be on the clinical grounds like development of hypokalemia, worsening liver failure, or hypotension, and they should not be directed by the COVID status. Initiation of the use of ACE inhibitors really in newly diagnosed hypertensive, diabetic, and heart failure should be according to the guidelines and clinical recommendations, and not according to the COVID status. While initiating, the decision should be taken on case-to-case basis. For example, a newly diagnosed patient with hypertension, no diabetes, no endocrine dysfunction can be tried with other antihypertensives. But in case of there is an evidence of endocrine dysfunction or there is a proteinuria, it is preferable to use ACE inhibitors or ARB. At this point, the use of ACE and ARBs as a treatment for COVID-19 is not well established. Further studies will be more useful in throwing a light onto the use of these as a treatment modality in COVID-19. Thank you.
Thank you very much, Dr. Pramod. And we'll move on to our next lecture. We'll request you to stay back so that we can have a question and answer after we finish. Next lecture will be by Dr. Mohan Maharaj. Can I have the credentials, please? Yes. Welcome, Dr. Mohan. And let me introduce him. He's the Director of Critical Care and Pain Management at the Medicover Hospital in Visakhapatnam. And he will be talking to us today about COVID hypoxia and delirium, my strategies to manage. So over to you, Dr. Mohan, for your lecture.
Hi, welcome to the World COVID Conference. At the outset, I thank Dr. Ramta sir for giving me opportunity to do this talk. Delirium in ICU and delirium in COVID-19 are very important aspects for three reasons. One, we all know that it is going to increase the mortality and it is having three types, whether hypoactive, hyperactive and mixed, which is most 80% is hypoactive. And also it increases the cost of the care and duration of the length of the stay. And particularly it increases the dementia post-ICU, which can last for years. And particularly in pandemic of COVID-19 or COVID duration of the pandemic, you have to save the beds and you have to have a surge so that you need to have a vacant beds. That's why you should take care of this delirium very seriously, and which is one of the important topic why we should talking about it. What is the definition of delirium? It's a syndrome with acute disturbance of consciousness from baseline mental status with inattention accompanied by a change in cognition or perceptual disturbance that develops over a short period of time and fluctuates over time. So this is the definition. And when you see diagnostic and statistical manual of mental disorders, 5 criteria for delirium, when you look at it, it is not a psychological disorder. It is a disturbance in attention and it develops over a period of time and it fluctuates day, morning to evening also. So when you do the rounds in the morning and evening, you may miss it. So, and there is a change in cognition, difficult to evaluate and which is easy. We use the psychometric tools and not explained by other disorders as we already clearly known about it. And it can be caused, we know that maybe medical condition or medication, because we will talk about it. The incidence, it's very, very vary because in Wuhan, in China, they said it's only around 30%. Later on, when you look into that, it's going to be 75%. And it varies from 15 to 85% actually. So it depends on the ICU, depends on the criticality and the patients. Actually, COVID-19 is a delirium factory by itself because the neurobiology of COVID, because it has entrance into the brain, and even though there was no RT-PCR negative in some patients, when they did post-mortem studies, it has been identified RT-PCR in the brain tissue, and it enters through the psychological, because this is one of the first brain dysfunction which can be identified, and particularly a lot of deliriogenic factors in ICU, and in COVID it's more so, and that too because of, we know, to prevent the spread of infection, we need to have isolation. That is one of the another cause of it, and it's inability to freely ablate by the patients. So that's the reason which is more compared to other. When you look at the many studies, this is one of the good and more number of patients included, even though if it is a multi-center cohort retrospective study, but it is having a good validity because the number of patients are around 4,530 patients. And in that, because the data is not good, able to retrieve it is from January 20th of 2020 to the April 28th of 2020, they would able to get this all the data from the almost 50% of the Spain and 50% of the America. and 14 countries and 69 ICUs, they got the data and properly, and with could able to get it around 2,088 patients only, and which showed this is the outcome of this study. When you look at the outcomes, almost 601 patients, 28% were died, and 1,416 patients were alive. But look at this, the prevalence, the males were more, and the duration of delirium, because that is going to matter the mortality and the duration, average length of stay, which is going to increase the stay. That's why the duration of the stay in the normal patients is particularly only a day, and but whereas in delirium in COVID, it is going to be minimum of 3 days, which is range from 5 to 7 days. So here the issue is that when you look at it, the pathophysiology itself in ARDS, which is a slow process in sepsis and ARDS, whereas in COVID, it's going to cause within a day or two, maybe it's get a spike over the second week. So that is the reason you should have you really look into that. The percentage of hyperactive, almost nearly not much difference, because only 51% difference, whereas in normal ICU, it is totally different of 80 to 20%. And look at the ventilated free days. And the day of admission, whether the patient requiring vasopressors, patients requiring ventilation, patient requiring sedation and agitated, that actually caused the patient more into delirium. And if you look at the forest plot chart here, you look at it, there is a antipsychotics patient was using, and continuous opioid infusions and more of benzodiazepines. And look at the ventilated type, whether you are having a non-invasive ventilation, because of the difficult availability of ventilation, you cannot really take care, and the patient already a smoker and alcoholic. So that is one thing, another thing which is caused more. Other few studies which are important by Kohn et al. And Helms and Jochel, where the number of patients are less, but they use the psychometric and tools, which actually they have you have a CAM ICU or nurse delirium scale scoring. And these are things which they looked into the patient's assessment and monitored and looked at the prevalence, which is starting from 45% to 85%. So this is actually the better, cognitive assessment method in ICU, how you can see. And they also understood this is the way they are getting, and these are the prevalence in ICU patients. We all know what are the reasons. And at the same time, particularly the problem here is that you really don't have a trained intensivist because of the pandemic, and the people are looking into the only core treatment of a disease and the disease prevention or disease prevention or the treatment. They have not looked into all other aspects like a faster DID and where the delirium comes in the later stage, because unless you have been known, you cannot see the eye through the eyes unless you know in the brain. So people are not trained for the delirium methodology and the scales identification and looking at the seriousness of the time because of the problems. So the simple few things are going to be very important. The IT services and end of life care support, psychological support, reassurance, and regular agitation and PAD guidelines. We have one of the very good ICU delirium.org is a very good website where I actually give you a lot of things, and to see the cognitive follow-up and to practice it through empathy, and also making the patients, when you go and do the rounds, you just do reorientation and family video calls. This is actually going to prevent these delirium risk factors. So the ICU delirium in COVID-19 is not much of a difference, but we need to identify because of 3 reasons. The one, the complications of COVID mechanism is faster and higher, and secondary inflammatory process is there, and there is a direct neural invasion because normally it is a retrograde neuro entry through the olfactory bulb. And that is the reason which actually people get into that. And normally, some people get it anosmia, agusmia, and that's what they get it. And with that early signs, you can know later on, which can enter into the hypothalamus and go to the brainstem, that can cause a respiratory depression. So the mode of entry is through olfactory nerve, the lymphogenic or hematologic. And this is a few patients which have been noted that suddenly people come to the ICU without normal signs and symptoms, RT-PCR positive, and they go into the neurological pathway. They seen antigen may be present in the brain tissue. And we know that is a viral RNA brain tissue identified. That's the reason we should keep this neurobiology of this COVID. And there have been evidence proven in postmortem. And there is a secondary inflammatory process because of the cytokine storm. We all know about it, which happens in second week of COVID, which can cause a leaky blood-brain barrier, which actually particularly goes to the temporal area, and where most of the time area which can enter, and that activation of the astrocyte, and this will cause the more of a delirium and the coma. Normally, acute brain dysfunction is a coma or delirium. So the delirium is a part what we are looking at, because if the patient is in coma for a longer time, it is often it's difficult to come back. So these are the main reasons why in COVID patients go into delirium, because of hypoxia, hypercarbia, acidosis, and there is a thrombosis, high coagulate disease. This is and because of the metabolic dysfunction and multi-organ failure. And you are going to see that the one of the important aspect of everyone's Society of Critical Care Medicine has given is A2F guidelines, and this A2F guidelines are going to really prevent. The reason why we are focusing and stressing this is that because of the delirium is a preventable thing, and really it doesn't have any pharmacological treatment which is useful and beneficial and reduce the mortality. Oh, this is by ABCDF, and look at the patient, assess, prevent, and management. And you manage the pain with the proper pain medication. Always treat the pain more than the sedation. And look at the what you're going to do. B is for you look at the breathing trial, spontaneous breathing trial, and look at the spontaneous awakening trial, which is going to be useful. And early extubation, we all know, early mobilization, we all know. And choice of analgesia, please, you give more of opioids and less of sedatives. So, and always look for the sedation score, whether the Richmond agitation sedation score is less than 4, or particularly we are doing in a COVID prone position or doing more. So that's why we should look at it and avoid benzodiazepines, which is very difficult because in the acute stage, we normally use it. And even though dexmedetomidine is one of the useful thing and which may be better than benzodiazepines, but still. So delirium assess, D is for delirium assess, prevent, manage. So this is another thing is mnemonic is that look at the drug removal and look at the patient depression is there and look at how you are going to take care of it, easy way of looking at it. And we all know early mobilization, even the patient on neuromuscular agents, ask the physiotherapist to have a passive mobilization and make the patient early end of the bed. If the patient is on HFNO or NIV, even on intubation, he can read the papers, he can go through the videos, he can have the family. Make sure that in our ICU, we make sure that 24/7 physiotherapists are available for the patients, except the patients are sleeping. And this is one of the tough job in COVID point of view, because of family engagement and empowerment. We are used IT and video calls, and particularly older people more than 70 years, we make sure that attendant is available if the patient is already positive having antibiotics with the PPS, so that they don't go into delirium. And that's one important thing which we made sure that for older patients there is a compulsory attendant is available with the proper PPS. And this is normally screening. When you look at it, there's a screening of patients, particularly in the ICU with the CAM ICU or nurse delirium scoring scale, and to be taken, which takes only 30 seconds, a maximum of 1 minute, will save and prevent this one. And identify the cause, whether it's infection, whether it's hypoxia, whether it's hypercarbia, which is easy to know it. And always, as I told you about how to look at ABCDEF, the follow the guidelines, which makes very, very important and prevents the issue of delirium. The pain, we all know CPOT score and behavioral pain score. When you have these scores, when you identify the pain, because screening scale, visual analog scale, normally we don't see the patient in ICU. So look at the scale and use more of painkillers is more important rather than looking at the sedation. Avoid benzodiazepines because, as you said, spontaneous breathing trial, when you're looking, awakening is also very important. Make sure that patient is awake, is not deeply sedated, so that the delirium is much less. And drugs, you always look for antipsychotic drugs, or the patient is already on alcoholic or having any withdrawal symptom, that should be taken care properly, whether he's having a proper medication is less or more. And physiotherapy, when you look at this patient on physiotherapy, as I told you already, that patient should be even in neuromuscular drug already on patient because of the acute ARDS prone ventilation, you make sure that the passive physiotherapy is done. And the intact GI tract important, we look at the fast track in ICU because, and we'll make sure that there is a clear cut feeding, bowel opening, everything is there. At the same time, constipation and bladder fullness, which is cannot be, these are the two things which actually be avoided, so that also can prevent delirium. And make sure that family and friends, as I told you, non-pharmacological methods is very, very clear, very important. As you said, that sleep cycle is important. Silent making the patient at the time, so no disturbance for the patient while they're sleeping. The noise of the ICU is very crucial, and regular orientation of the time and place, because when you go for the rounds, make sure and ask them and get acquainted with the patient, and light and as well as the time and those kind of things are going to really be making him come into the normal condition, even though make them the understanding the critical condition. That is one of the important factor which is in our hands. And family and friends, this is another important aspect which normally prevents and definitely improves the patient's satisfaction. So what I would like to tell here is that the modifiable factors and non-modifiable factors, one of the important aspects is that family and friends, and avoiding the sedation more and stopping the benzodiazepines, and early identification, looking at the pain score and looking at the particularly psychometric tools are very important, which takes up only 30 seconds to 1 minute. We can assess the patient and prevent the condition of the delirium, because there are 4 points, as I told you in the beginning: the cost of care and duration of average length of stay in the ICU, and the patient mortality is going to reduce if we can prevent the delirium, because preventable disease and preventable thing is delirium. There's no pharmacological treatment for the delirium. And also, particularly in the pandemic time, you should be able to really make sure that there is no problem, and the availability of ventilator and availability of personnel. Because of the very difficult arrangement of personnel, we should go into the methodological way and assess the ABCD of bundles properly. So thank you very much.
Thank you very much, Dr. Mohan. And it was a pleasure listening to your thoughts. And we have our next lecture right now by Dr. Soren Panja. And he'll be talking to us about the Kolkata protocol and the experience. Dr. Panja is the head and senior consultant in the Department of Critical Care Medicine and Internal Medicine. He's the administrative lead for critical care services of the Eastern region. So over to you, Dr. Soren, for your lecture. We'll be looking forward to hear your Kolkata protocol.
Good afternoon, everybody. So at the outset, I must thank World Conference on COVID and Critical Care. And this is a relatively new concept that has bring up by the organizers. And the present topic is basically the COVID-19, the Kolkata protocol and experience. And regarding that topic particularly, as such, in Calcutta, there is no critical care, no different protocol, but it is a state guidelines that I will follow. And about the clinical features of the COVID-19 that we know, so these are the common symptoms: the fever, dry cough, shortness of breath, aches and pain, nasal congestion, runny nose. These are to start with. But after that, there is basically symptoms may aggravate in terms of the different kind of respiratory symptoms, gradually progressive, shortness of breath, then cough, and other system involvement, and sometimes other organ system like nervous system or the cardiovascular system may get affected. And with this background, sometimes the patient may be mildly ill, or sometimes patient may be quite sicker, and the syndrome may be in COVID-19 may be uncomplicated illness that can be treated at home, or sometimes they may come out with mild pneumonia. And if the symptoms progresses, then there may be severe pneumonia, acute respiratory distress syndrome. Sometimes patient might have a sepsis or septic shock like presentation. And in some patient, there may be other organ system involvement like liver, kidney, or the nervous system that can lead to the multiple organ system involvement. So it is the severity of the symptoms that actually finally decides about the outcome of the patient as well as mortality, morbidity. And this was the start of in the beginning, there was in India, there was 2 peaks, and in West Bengal or in Kolkata, the same thing we have also followed. Usually after a lag of 15 days to 1 month from the rest of the India. And if we look at our mortality as well as the survival curve, during the initial part when the COVID-19 actually started in India, in the month of February, March, April, that time the mortality was relatively higher. And that may be because that time the understanding of the disease as well as the management was not that great, as well as the kind of the staffing and the system
geared up was not that good. So that's why that may be the initial part. And gradually, as the time progresses, we have come out with different type of treatment as well as some evidences of the treatment the good effect of the treatment. So accordingly, if we look at the survival curve, the mortality remains more or less between 1 to 2% amongst all the COVID-19 patients. So it has not been changed. And if we look at the Calcutta scenario, in the Calcutta or in the West Bengal, but in particular, there is no case definition of the COVID-19. It is more or less same with the rest of the countries. And testing strategy of the COVID-19 as far as the ICMR guidelines, it is the gold standard guidelines is RT-PCR. So that should be followed to say that patient is COVID-19 positive or negative. Though there are other screening tests are there, and treatment strategy of COVID-19 that I want to highlight because of the time constraint, I don't want to waste my time. The trajectory of the practice means basically management of the COVID. There are initially to start with, there was sometimes we don't basically this is a new disease, new normal. So we have followed with the sometimes extrapolated with either other viral diseases. So there was experience-based medicine, evidence-based medicine, empiricism, as well as science. So gradually it has progresses. So right now there are good amount of evidence as well as the science that we practice in our day-to-day practice. And if we also look at the different type of the treatment. So initially some of the treatment that was initially we were using like chloroquine, hydroxychloroquine, azithromycin, colchicine. So this has been basically dumped in the outside. So presently the therapy is therapeutic outlines is basically mostly antiviral definitive therapy like remdesivir, corticosteroid, anticoagulant, or anti-IL-6 inhibitor. So that is being practiced. And if we look at depending on the illness phase, so what are the different type of treatment available? So that the same thing, whatever is basically standard guidelines is following outside India as well as in India, national or international guidelines. Our state guidelines basically is always has issued different guidelines with the time frame, and accordingly we are practicing with the state guidelines. Along with that, there is also a mention that because of the emergency use authorization, there is also a flexibility that some of the hospital or the doctors, they have their freedom to practice other medicine depending on the available evidence. So accordingly, these are the different type of treatment available, and as the symptoms progresses and severity increases, the treatment intensity as well as different type of the other medicine that may be used. So because in the initial part, once the patient is relatively in the day of say 5 to 10 days, within that period, if the patient is not without any oxygen therapy, so this is the newer therapy that is in India that is available, that is cocktail therapy like casirivimab, indemivir. There are other monoclonal antibodies that is also available that may be used during the initial phase. And particularly if there is any high risk patient, particularly more than that I will just discuss. So high risk patient, they may be offered with that type of therapy. And this therapy for last 3-4 months is available, but definitely the COVID intensity or the COVID incidence has decreased. So we have some limited experience with that using of this cocktail therapy in our own patient, but we have used in a couple of patients in Calcutta also. So this therapy is basically monoclonal antibody, whatever is available presently right now, indemivir and casirivimab. It is been marketed by one particular pharma brand, and this cocktail or this type of monoclonal antibody, they paralyzed the spike protein of the COVID virus. That actually helps in reducing the infectivity of the viruses as well as the number of virus replication actually has come down. So that may limit the disease process. And these are the different type of indication that we are also practicing in Calcutta, like age more than 40, 60 years, obesity, cardiovascular disease, chronic lung disease, some immune suppressed condition. So these are the high risk patients where we can use this type of therapy. Best one is if we can use within 5 days of the year. So other than that, if the patient is getting admitted in the hospital, so in the hospital, if the patient is suffering from moderate to severe illness, that time the remdesivir is there. In Calcutta also there are recommendations. So we are using for the moderate to severe illness for the remdesivir, preferably if the patient is within 10 days of their illness. But if a patient is more than 10 days of illness or patient is already ventilated requiring very high oxygen requirement, that time it is not the ideal drug, or sometimes the benefit really may not be there. And some condition like hepatic renal failure or pregnancy, the therapy is also, we have to judge about the risk benefit ratio. So for that, the state guidelines of Calcutta, the most of the physician practice or follow the state guidelines in the same line as they have given. So I am not going in details about the remdesivir. There are certain evidences. So whether to use, whether not to use, till now it is a relatively debatable issue. About the corticosteroids, so most of our patients in Calcutta, whoever is moderate to severe illness, that time this is the indication where we should use corticosteroid. And if the saturation is less than 95% or patient is requiring oxygen or any form of the ventilatory assistance like non-invasive ventilation or ventilation, mechanical invasive ventilation support, that time the corticosteroids should be used. So, but it should not be given if the saturation is maintaining more than or equal to 95% and patient is not having the mild illness. So that time it may not be, it is not necessary. So unnecessarily patient maybe rather might have some other complications, and there are evidences. So in regarding the corticosteroid, we are using in the same line as with the national or other international defined guidelines. But regarding corticosteroid, the doses are relatively higher what has been mentioned in our state guidelines. So it is at the tune of, say for say for example, dexamethasone, the dose is approximately 24 milligram per day in divided doses for the severe illness. For the moderate illness, they have mentioned that the dose may be 6 to 12 milligram per day in divided doses. Regarding the tocilizumab, this is the IL-6 receptor antagonist, so that may be used. So if a patient is basically within 24 to 48 hours of the admission and patient is requiring high oxygen requirement, or gradually the patient respiratory assistance is increasing, that is the time the tocilizumab has been included in the guidelines. But again, the government has not encouraged much about the use of the tocilizumab. That may be because it was not easily available. So that may be the reason that government has not given too much of pressure on the tocilizumab. And some of the patients like active sepsis, tuberculosis, or active hepatitis, AST, it is more than 1.5 times than the upper limit. That time it should not be used. And some doctors use the procalcitonin as indirect sepsis marker prior to use of the tocilizumab therapy. And regarding the anticoagulant, also either heparin or low molecular weight heparin, that is a standard of practice in Kolkata. So that all doctors, they are using this type of therapy. And regarding the dose, there is a variation. Some doctors prefer to give a little higher dose, though the state guidelines for the severe illness or if the patient is on ventilator, that time they have given a twice daily dosing than the prophylactic once daily dosing. And regarding the NOACs or novel anticoagulant, the state guideline has not mentioned any, has not given any guideline. So for that, there is flexibility about the depending on the doctors as well as institute specific practice. About the baricitinib, that is, though it has been basically not in our state guidelines, but Kolkata, most of the doctors, they are using the baricitinib. So it is basically used in the hospitalized patient requiring oxygen or non-invasive ventilatory support, and usually prescribed along with the remdesivir. And alone as baricitinib is not used much. Regarding the convalescent plasma, initially there was an enthusiasm about use of that convalescent plasma. But because of the result of the PLACID trial, after that, the state guidelines as well as the one local, most of the doctors, they don't give convalescent plasma as they used to use it in the earlier phase. And regarding the oxygen therapy, defined type of oxygen therapy, that may be so oxygen therapy basically like your nasal cannula or mask or HFNO, that depends on the type of patient. And basically the target saturation should be maintained between 90 to 96%. So gradually the hierarchy is that we use usually in Kolkata nasal cannula. If patient is not maintaining saturation, then simple face mask, Bensuki mask or non-rebreathing mask may be used. HFNC and NIV both are available right now. Most of the hospitals, initial part there was less number of HFNC was there in most of the hospital, but later on it was being basically covered up because the state government has also supplied some of the HFNC machine to each and every hospital. So in our hospital also, or most of the hospital, they are practicing the HFNC if the patient is requiring relatively higher oxygen support and the work of breathing is not much high. So usually most of the Calcutta doctors are prescribing if the requirement of the oxygen is more than 6 to 8 liters, then the HFNC may be actually offered, and it reduces the work of breathing as well as some of the patient it might have some peak effect as like any other thing, and it has also the experience is quite good in regarding the HFNC use. And about the NIV support also, if the patient's work of breathing is relatively low and patient is not doing well with the HFNC, that time NIV may be supported. But again, the thing is that if the patient on NIV not doing well, so that time it may be, so the patient may be put on the invasive ventilation. And regarding the invasive ventilation, our indication is like any other patient with the respiratory failure. Though there is a trend that for the NIV support as well as HFNC, the most of the doctor prescribe actually switching from the non-invasive to invasive. There is a little delay amongst the doctors or the institute. The reason may be most of the time they feel that the HFNC or NIV patient can be managed, so that will be better. Not only that, initial perception was that invasive ventilation there is more mortality. Most patients receive prolonged HFNC or NIV before intubation. So most center practice rapid sequence intubation in a negative pressure area. Sedation and paralysis is maintained for at least 48 to 72 hours. And during that patient, sometimes patient may be prone if the institute is having enough support, manpower support as well as expertise regarding the prone ventilation. And FiO2 titration should be to maintain a saturation of 92 to 94%. Mode of ventilation, either pressure control, volume control, or PRBC. So everyone is practicing according to their local protocol. And proning with ventilation is advocated for better outcome. However, the process is resource intensive, winning as per the standard protocol guidelines. So in summary, in Kolkata, we follow the guidelines laid by the state, national or international bodies. That is little depends in some of the practice parameters. Practices vary amongst the individual doctors and hospital. There is a trend towards overuse of antibiotics and antimicrobials that has been basically we have discussed in different forum in Calcutta. Steroid use in respect to doses and as well as the duration also differs from the standard recommendation. So sometimes the doses are relatively higher in comparison to the international guidelines, and sometimes the duration of the steroid use is also relatively maybe sometimes 4 to 6 weeks. So that may not be applicable for each and every patient, but definitely there is a trend of using a prolonged steroid in Kolkata. And there was a shortage of essential medicines and equipment, resulting in diversion of practice from the standard practice. So that way, some of the practices may be little different from the national as well as international guidelines and as well as practice. With this, I hope that I have basically whatever I have focused, it is some of the practice parameters as well as the guidelines that has been followed in Calcutta as well as in the West Bengal state. So I thank you all for patient sharing, and if there is any question or discussion that may be put on, and I will try to discuss all those issues.
Thank you very much, Dr. Soren. And I think with this, we finish all the 4 lectures. I don't know whether we have time for questions. And do we have any questions from the audience? I don't see any questions, but I think we have run out of time. I'll just ask a quick question that I think Dr. Pramod really mentioned about ARBs. And there was a whole swing from earlier that ARBs and ACE should not be used from the, and then there was some data that it is protective. So is the verdict out very clear that we should use ARBs in patients who are already taking them, and what should be the way forward in terms of message?
I think the use of ACE inhibitors and ARBs, it was in the initial stages with the first wave, they were putting a stop on, particularly in those set of patients who are on ACE inhibitors or ARB. But it was subsequently found that the withdrawal of the ACE inhibitors and ARBs, particularly in the patients who are on long-term ACE inhibitors, had worse outcome. So this led the societies, particularly the American Heart Association and the European Cardiology Association, come up with it that in those set of patients in which the patient is already on ACE inhibitors or ARB, the ACE inhibitors and ARB should be continued on to, rather than stopping these ACE inhibitors and ARB because of its anti-inflammatory, because of its pro-inflammatory action, because With the ACE inhibitors, if they are stopped, the angiotensin 2, as I've already discussed, is increased, as a result of which there is a more of angiotensin 2 acting on AT1R receptors, and that results in the development of what is called as the inflammatory pathway. So ACE inhibitors and ARB, withdrawal of it is found to be having a decremental effect in patients of who are already on ACE inhibitors and ARB for some or the other reasons. Sorry, I'm not audible. Your mic is mute, sir.
Sorry.
Your mic is mute.
Thank you very much. Thank you, Dr. Pramod. I think that was an excellent answer. And I'd just like to ask a quick question to Dr. Rajan, that there was a lot of spike about hyperglycemia as a, as part of the treatment, post-treatment. And people did end up getting a lot of decays in hyperosmolar states. So what is your experience and how did you really cope up with this situations to avoid decays? Were you aggressively insulinizing them? How was the hypoglycemia concern for your patient? I think you're muted. We can't hear you.
Am I audible now?
Yes, you are. Thank you.
Thank you. Actually, hyperglycemia was seen in both types of patients, those who already were diabetic and on admission when most of the time their oral anti-diabetics were withheld and they were shifted on, I'm talking about moderate to severe category of patients who were hypoxic. In those patients, they were naturally shifted on insulin injections, either a novorapid injection, ultra short acting or a long acting ones. So in those patients, controlling their sugar was difficult and unpredictable as well, especially when they were simultaneously put on steroids. And well, as far as decay is concerned, there were very few patients who actually had a diabetic ketoacidosis, but most of them had just plain simple hyperglycemia, and that was managed either with a continuous infusion and titrating their insulin scales on the hourly basis and sugars also. But it was definitely a challenge. Most of the time the sugar used to be more than 150, 200, and it used to be very difficult to control them. It used to take at least 2 days, 3 days sometimes to bring them to an acceptable glycemic range. Yeah.
Were you coping with a lot of hypoglycemias during this period when you were doing, because there was a lot of glycemic variability that the patients had?
Yes.
So, was hypoglycemia a very major?
I remember one or two patients had a hypoglycemia, and but that was not very low, but however in the range of around 80 to 60 to 90 range. And they became symptomatic, they become delirious, and I'm sure that is one of the reasons for being sudden delirium in ICU. Patients start behaving in a confused state. So, and this was mistaken as a hypoxic encephalopathy as well. However, it turned out to be a hypoglycemia.
Just like to ask a quick question to Dr. Mohan, that in patients who have got a very advanced disease and who have ended up with a lot of lung problems, and they ended up even, having hypoxia, which continued even after they were shifted out of critical care units, even at the time of discharge from the hospital, and the mental obtundation that they had at times. How was the best way that, families could cope up with these sort of a situation who ended up with bad lungs, hypoxia, and mental obtundation? How long do you think these things last, and is there a hope that they will recover or they continue to be hypoxic in that situation?
Actually, thanks for the question, but whoever it is, the important point I would like to note here is that there is a multidisciplinary COVID rehabilitation, which takes care of all these things. The UK government has given guidelines of these nice guidelines. And with that, normally we have given almost 100-150 people with oxygen concentrators. We have discharged them home with the rehabilitation centers. And following the, as I said, my topic, even the delirium, the question belongs to the actually Nintinab, and which is useful more than a month or 2 months we use it. And following them after 3 weeks is definitely beneficial.
psychological support and counseling has been used for them, and particularly the muscle wasting and nutrition parts taken care very much.
Thank you. And my last question to Dr. Soren, that primarily now with the antibody cocktail that's come in, a lot of aggressive early onset disease is being treated by antibody cocktails, and at least where I come from, there has been a very free use. Every time somebody's got diagnosis of COVID, now is opting for an antibody cocktail. Is there a very clear guideline as to who should be the prioritized to get the antibody cocktail? So is there, let's say, a 5 criteria or 6 criteria to say that these people should not be given and these people should be given antibody cocktails? Given that we've got a very short time window to give the antibody cocktail. Dr. Soren, are you there?
Sir, he's not there.
Okay, he's not there. All right. I think with this, we'll conclude this session. I think it's been a very interesting and informative session that we've had. We've run out of time, but I think pleasure to listen to all of you. Great thoughts, and wish you all the best. Thank you so much. Over to the organizers.
Thank you. Thank you,
Bye.
all the panelists.
Bye. Thank you, everyone.
Speakers. Thank you.
Bye. Thank you very much.
Thank you.
Thank you, everyone. We now move on to the second thematic session for the day, where to chair the session, I welcome Dr. Saurabh Bhargava, Professor and Head, Department of Emergency Medicine, Consultant Neuroanesthesia and Critical Care, NIMS, Medical College, Jaipur. Dr. Payal Saxena, Anesthesia and Critical Care Expert, Head of Department, Global Rainbow Healthcare, Agra. Dr. Rekha Das, Professor and Head of Department of Anesthesia and Critical Care, Pain, MD FCCS, Acharya Harihar, PGI of Cancer, Cuttack, Consultant and Advisor ICU, Shanti Memorial Hospital, Cuttack. I now request Dr. Rekha Das to please introduce the speakers for this session.
Yeah, a very good afternoon to all. I think we are missing out on our first speaker, Dr. Babu Abraham, on the Chennai experience. We move on to our second speaker, Dr. Anup Kumar, who would be speaking on the Kerala protocol and experience. So he is the Chief of the Critical Care Medicine at the Baby Memorial Hospital, Calicut, Kerala. And he will be bringing to you highlights about the Kerala protocol and experience. We have all seen that Kerala has done a wonderful job. It was a pioneer in managing COVID. It was, in fact, the COVID first started there, and they have always been prepared for any kind of pandemic. And it is always a pleasure to have them here to share their experience, how well they have managed the show. So now over to Dr. Anup Kumar, please.
Good afternoon, friends. I'll be talking on the Kerala COVID protocol and our experience in using this protocol and in treating this disease in Kerala. As you all are aware, in India, on Jan 30th of 2020, Kerala reported the first case of COVID-19. After that, we had very good containment activities in Kerala. Actually, that was the first experience in India. And with the good containment activities, the number has almost come down to 0. But later on, we also had huge outbreak in Kerala. We had almost 80,000 total confirmed cases so far. But the mortality rate is so very less, only 0.56%. But the unfortunate thing is, still we have a good number of cases being reported with a test positivity rate still above 10%. Coming to our Kerala protocol. So the main difference in Kerala protocol was, along with other severity categorization, A clinical categorization was also included in the protocol based on our influenza categories in the previous years. I don't know whether it is completely correct in adopting such a categorization, but the explanation given was the healthcare workers were already used to such categorization. So we had a category A, B, C, where A will be only mild disease with mild symptoms without fever. If the patient is having along with the category A symptoms, if they have a fever with severe sore throat, cough, diarrhea, etc., or if they are having any comorbidities, or if they are pregnant, or if they are more than 60 years, they are categorized into category B. And category C, where they will be having chest pain, breathing difficulty, low blood pressure, hemoptysis, or cyanosis, or the children with influenza-like illness with red flag signs, or worsening of underlying chronic conditions. These are the category C illnesses. And in Kerala, we had 5-tier COVID care pyramid, where asymptomatic home care isolation was done like every other state. Along with that, and another step where the domiciliary care center was initiated. This is for asymptomatic with no provision for home care and self-isolation. If they don't have a separate room and a separate toilet, so with the help of the local governing bodies, they were given these domiciliary care centers. This is basically for isolation purpose only. Then the category A patients were given in CFLTC or the first line treatment center, and category B like that is a line treatment center or CSLTC, and category C where we have designated COVID hospital. So this was this is the 5-tier system we are following. And based on the comorbidities, clinical assessment, and lab values, there was a risk stratification as well. The one important thing was HbA1c was included, and along with that, other routine parameters and the inflammatory markers as well. Coming to the treatment category, like everywhere, the symptomatic treatment only was given for mildly symptomatic patients. But in category B, patients with fever or significant symptoms without hypoxemia, they were given inhaled steroid like budesonide, 800 milligram twice daily, based on the newer two trials. And in category C patients, the budesonide inhalers were continued, and along with that, the steroid was used on the slightly on the higher side for the severely sick patients, where methylprednisolone was used almost 2 mg per kg, and dexamethasone was used 0.4 mg per kg. Along with that, anticoagulation as per the routine protocol. But in moderate illness, the routine, the steroid dose was continued. So the one change was the early initiation of inhaled corticosteroid and a slightly higher dose of IV steroid in severe patients. And this was another major change, as you all aware. Like the steroids are indicated whenever there is hypoxemia. There is no doubt about that. And there is slight confusion regarding the moderate illness, how it is defined. But here, what in Kerala protocol they did was, based on the exertional desaturation or a 6-minute walk test or an HRCT thorax, if there is a significant ground glass opacities, or if there is an exertional desaturation, then the steroids were initiated without hypoxemia. So the moderate illness also was initiated on steroid based on the clinical or the radiological parameters. The monoclonal antibodies are also included in the protocol. This was available in the government setup till a few weeks before, like in many other states. Now it's not available in the government sector, but the private sector it is given in indicated cases when people are affordable. So this is the present situation in Kerala. Like last 4 days, you can see, on an average, we have 75 to 80 deaths per day. and around 7,000 to 10,000 confirmed cases still happening every day, and the active cases is somewhere around 80,000 plus. So we are still in the outbreak. There is the second wave was not completely settled in, and this is the way we had an initial like a slow peak in September, November, etc. It was not a huge peak. Then that was the first wave. Then following which in May, like in any other part of the country, we had the second outbreak, but that has not settled completely. And the second outbreak has again peaked. So we don't know whether it's a third like peak, but it's a continuation of second outbreak, second peak, and now it is gradually settling. But still, we have 5,000 plus cases every day. And this I've already told. The cases was initially started in 30th January, but it was well contained till October, like September, October. Then had like an outbreak. Then again, the second outbreak is continuing now. Now, when you compare the Kerala data with the Indian, the national data, you can see the total cases I've already told it is nearing like 50 lakhs now. And the case per million is very high. You can see like 1,31,000 compared to 24,000 in India. So the case per million is too high in Kerala, maybe because of high population density. And still we have a higher number of active cases. But see, even with this many case per million or and infection rate, the case fatality rate compared to the national data was very, very low. And again, you can see the test per million was also almost, you can see when the national was almost, you can see like for somewhere around 4,07,000. Here we had almost 9,94,000. So almost the double the test per million. So the test was definitely high. So that may be the reason why we have detected more cases. And that may be one reason why the case fatality rate was also less. We might have picked so many asymptomatic cases. The test positivity in vaccinated individuals is the recent data in the September end. Like you can see, non-vaccinated still predominates, and followed by one vaccinated. But in two vaccinated cases also, the fully vaccinated individuals also, the reported cases are almost 21, almost around 22% of cases. Like everywhere, the asymptomatic, the cases are more. The symptomatics are almost 26%. And another thing was, like, we started doing this genomic sequence from early days onwards, and total samples tested so far is almost 7,600. And we have mainly the Delta variant. But one thing you have to keep in mind, the sequencing was started during the second outbreak. So we can say the mainly the Delta was causing the second outbreak, like any parts of India. Along with that, we had Alpha, Beta, Gamma, and other variant of interest as well in Kerala. So another good thing happened is, like in Kerala itself, previously we were depending NIV Pune and IGIB Delhi. So now in Rajiv Gandhi Institute in Trivandrum and the VRDL in Calicut, we are doing the sequencing. The whole genome sequencing itself was done in Rajiv Gandhi, and now we started doing a spike protein sequencing also. So we have the facility to do the sequencing now in Kerala itself, and to know the variant, majority of the time, the spike protein sequencing will be enough. You may not need a whole genome sequencing. So this is the data. Like as you can see, the previously there was a huge difference between vaccinated, non-vaccinated, and one dose. But now that difference is coming down. That means more and more people are getting vaccinated. And another like worrying thing is, even among the deaths, almost 8% of deaths are happening among completely vaccinated COVID patients. And this is another thing happened in Kerala. Even though we had so many patients, we are highest in the vaccination status in India. Almost 94% above 18 years are vaccinated with one dose, and two doses we are reaching almost 50%. I think the only state in India was done 50% two-dose vaccination in eligible population so far, and crossed almost 94% of single-dose vaccination. And healthcare workers, the vaccination rate is almost 90%, and one dose is 100%. And like other age group also, we have this e-Sanjeevani OPD, that is the tele consultation system, which is happening very smoothly. Even in rural areas, the people can access that, like especially those who are having symptoms or COVID positive. The psychosocial support using the social workers and the psychiatrists and psychologists were offered those who are in home care regarding their anxiety and other support system. And this is also working well in Kerala. And this is another thing happened in Kerala called the COVID Brigade, where the people are recruited, including healthcare workers, doctors, and other active volunteers for the care of these COVID patients and other supporting system in COVID treatment areas and other COVID related patient transport and other areas. And even the voluntary agents were also created, especially in the rural settings and the local self-governing body level. And that has also ensured the people are taking care of proper the quarantine technique, and when they are in isolation, they are not coming in contact with other persons. But what failed was the in-house the isolation facilities were not that good, what we feel, because there was so much positivity rate among the household contacts. So that may be a slight failure. So how we are proceeding now is like the second dose eligible people and first dose remaining people, we are trying to complete. I've already told we have reached almost 50% in second dose and 94% in first dose. And now everybody is concentrating on school and college reopening, and random testing to identify the clustering are being done, and all the facilities in the schools are happening. And out of active positive cases, people with the comorbidity, they are trying to get admitted in the hospital itself, or we are providing care in the hospital itself. The people with not knowing their comorbidity status, they are being tested for the morbidity and other the chronic illnesses. The symptom surveillance of remaining active cases under home isolation being done, and special focus on patient with diabetes, hypertension, and kidney disease. This is also happening in this month. Thank you so much, and I'll be happy to answer your queries towards the end of this session. Thank you so much.
Thank you, sir. Now I would like to request Rekha ma'am to introduce Dr. Josh, sir.
Good afternoon, sir. I have the privilege of introducing our next speaker, Dr. Jose Chaco, actually, who needs no introduction. Sir is the intensive care physician at Narayana Hospital, Bangalore. And sir, you all must have come across his blogs that he sends repeatedly in different platforms. And he would be bringing to us, speaking on pathophysiology of COVID, the current misunderstanding. Over to you, sir.
Hello, everyone. When COVID-19 hit us with unprecedented fury back in early 2020, we knew very little about the disease. And all sorts of myths were being propagated at the time regarding causation, transmission, and possible modalities of treatment, starting from eating garlic to mouthwashes, from hydroxychloroquine to ivermectin to lopinavir. There were any number of remedies being offered at the time, much of which has been proven to be plain witchcraft in the last several months. Most of the information we had at the time was extrapolated from SARS-CoV of 2003 and the MERS infection back in 2012. So there were gaps in our knowledge at the time and plenty of misunderstanding. And what we would try to do is to dispel some of the misunderstanding during this very brief presentation. How does the virus enter the body? We know today that the coronavirus attaches itself to the ACE2 receptor, gains entry to the cell. Once inside the cell, it sheds its RNA, and then the RNA takes over the mitochondrion of the cell. It forces the mitochondrion to replicate itself. Several fold, zillions of copies of RNA are made, and these become viral particles, and they spread to within the cell and to outside the cell, to the neighboring cells, to other organs as well. So that causes the virus to disseminate rapidly across the body. How does it enter? The nasopharynx is the primary route of entry, where it stays, colonizes, and in many patients, it confines itself to the nasopharynx and doesn't cause any further problems. But unfortunately, in at least some patients, it goes down into the lung, which is the primary organ that is attacked by the SARS-CoV-2. How does this happen? There are many theories. The most plausible of these are, first is microaspiration from the nasopharynx. And it's also possible that the force of airflow may actually conduct the viruses down the airways and into the lung and hit the lungs with fury. Now, what happens within the lung? In the alveolus, there is infiltration with neutrophils, T lymphocytes, monocytes, and macrophages, and there is an intense inflammatory reaction. Plasma kallikrein generates kinin, which attaches itself to the kinin receptor in the alveolar endothelium, and that results in vasodilatation on a large scale across the lung. So there is a very high blood flow across the lung due to pulmonary vasodilatation. And hand in hand with that, you have increasing edema within the lung, like in typical ARDS due to a leaky capillary membrane. And thrombosis also occurs within the pulmonary capillaries. So you have thrombosis within the lung, within the capillaries of the lung, which causes dead space ventilation because you have preserved ventilation, but no perfusion or reduced perfusion, and that constitutes increased dead space. You have pulmonary edema, which results in a diffusion barrier across the pulmonary capillaries, resulting in hypoxia. And later on in the course of the disease, you get fibrosis to a greater or lesser extent. Fibrosis may be largely irreversible, and it causes a right to left shunt within the lung, resulting in persistent hypoxemia in many patients. Thrombosis particularly is very common in COVID-19. It occurs, according to different studies, in 21 to 69% of patients, compared to a mere 7.5% in general critically ill patients. So the endothelium takes the brunt of the attack by SARS-CoV-2. And the basic problem here is excessive reactive oxygen species. And the antioxidant mechanisms, unfortunately, failed to combat with the excessive reactive oxygen species, which results in infection leading to hypercoagulation and thrombosis, and then later on, multi-organ failure, coagulopathy, and bleeding, like you see in many instances in bacterial sepsis. And that, of course, leads to not just one organ, but multi-organ failure. We know that ARDS happens, and apart from that, you can get encephalitis, encephalopathy, Guillain-Barré syndrome in the brain. On the heart, you can get myocarditis, LV dysfunction, coronary artery problems. In fact, one of our first COVID patients was a young man in his 30s who presented with acute myocardial infarction, and he turned out to be COVID positive. And then you can have hepatic dysfunction, acute kidney injury is a major complication that carries high mortality with severe COVID-19. So typically in the lung, you get ground glass opacities initially towards the peripheries of the lung. This may later on become widespread, quite extensive, involve both the lungs and give rise to a severe ARDS kind of picture. And that results obviously in reduced diffusion across the lung, severe hypoxia in many of these patients. And as I mentioned before, there is intense vasodilatation and increased pulmonary blood flow across the lung, particularly in areas of the lung which have no ventilation. So that constitutes a shunt within the lung. Normally, when you have lack of ventilation in a particular area of the lung, the blood vessels in that area reflexly vasoconstrict to prevent this shunting from happening. But because of the inflammatory response and the vasodilator response, hypoxic pulmonary vasoconstriction is lost, and that results in preserved blood flow through unventilated areas of the lung, which essentially means a right to left shunt within the lung. Thrombosis occurs within the capillaries and even bigger blood vessels within the lung. Silent hypoxemia is reasonably common in many patients. Patients may be tachypnic, they may draw large tidal volumes, but subjectively they remain fairly comfortable, which may indeed be misleading. But now, of course, we are used to it. We've seen many of these patients over time. One of the most important things to keep in mind is the possibility of patient self-inflicted lung injury. If your patient has mild disease to begin with, and then he progresses to severe disease with increasing breathlessness and a high respiratory drive, results in increased transpulmonary pressure because of the intensely negative pleural pressure. That results in what is similar to negative pressure pulmonary edema with increasing capillary leak and increase fluid collection within the lung. So somebody who is not so sick to begin with, if you continue to maintain them on spontaneous ventilation or perhaps with NIV or nasal, high flow nasal cannula for an extended period of time, they might develop self-inflicted lung injury, which you need to be wary about. Although the evidence is not very robust at this time, it's reasonable to assume because we have seen many patients who have gone down that route. Early during the pandemic, Luciano Gattinoni and his colleagues described two different phenotypes in COVID-associated IRDS. Type L, which is the low elastance type, low elastance or reasonably preserved compliance type, and the high elastance type with lower compliance. The low elastance type or high compliance type is probably during the early phase of disease when the lung is not affected to a large extent. The lung weight is low and the recruitable lung is also not very much. So that's perhaps the early phase of disease. And if your patient worsens, it can transition very easily to the type H or high elastance phenotype associated with low compliance. Compliance and elastance are inverse to each other, as you know. So in the low compliance type or the high elastance type, you have increased right to left shunt because of the reasons that I mentioned before, vasodilatation and high blood flow across the diseased lung. High lung weight, the more the lung gets solidified, the weight of the lung will increase. And there is increased recruitability at this stage as well. So these phenotypes were described during the early stage of the pandemic. The distinction may not be so clear-cut. One may very easily emerge or they may turn into the other phenotype within a matter of a very short period of time. So during the early acute phase of disease, you get the changes you normally see with ARDS in most viral and bacterial disease processes. And then later on in the disease, you get this kind of picture with intense fibrosis, characterized, and this is actually driven by transforming growth factor beta, which is seen in cancer cells, and they convert epithelium and endothelium to mesenchymal cells, and they become fibrosed. And this fibrosis can result in a picture like this. I still remember we had a man in his 40s who was with us for close to 2 months. He was on the verge of dying several times, but in fact, he improved slowly, came off the ventilator. And when he went home, he had big bullae like this. When he required oxygen, for a very long time. Currently, he is off ventilation and able to do minimal physical activity. So that's the end result of severe COVID, severe ARDS, and can result in intense fibrosis, as you see on this image. So to sum up, the SARS-CoV-2 virus spreads from the nasopharynx, from the upper airways to the lower respiratory tract, and the lung takes the major hit as the first organ to be hit. And in roughly 5% of patients, you get severe COVID-19 with severe involvement of the lung. Transmission is very high, particularly during the incubation period of the disease. And that's when people are unaware that they're infected and they can spread it to people who are more vulnerable, particularly those with comorbidities. Epithelial and endothelial cells are affected primarily within the lung, but it can result in involvement of other organs over time. SARS-CoV-2 infection, COVID-19, is a thromboinflammatory condition typified by widespread thrombosis and inflammation combined, and this takes the form of extensive clotting within the lung and also within other organs as well. The viral load correlates with the severity of the disease. That's been clearly shown, which again shows that the ability of the body to mount an immune response and kill the viruses early may be important. If you mount a good immune response, you may escape severe disease. That's it, friends. Thanks a lot for listening.
That was an excellent talk by Jose Chacos, sir, and he's deliberated so well. Sir, can I ask you a question, or would I take questions at the end of the session?
I'm here. You can ask.
Yes, sir. Sir, considering that many think that the delayed, the prolonged hypoxemia could be due to a delayed ground glass appearance opacity prolonging for a long time, or it could be due to fibrosis. How would you distinguish them? Would you go for a CT scan, or would you give them empirical treatment based on your clinical findings? How would you know that this patient is having a delayed ground glass opacity resolution, or the patient is already fibrosis has set in, and that would change your treatment course?
I understand. You're asking how do you distinguish between acute COVID versus
and accordingly
fibrosis.
Treat these patients. Yes.
Yes. So we have not been doing CT scans regularly on these patients to look specifically for fibrosis.
Exactly, sir.
If they don't improve within the first couple of weeks, you assume that fibrosis is probably settling in, and we tend to empirically start nintedanib is what we use currently on these patients, and our experience is only anecdotal. I really can't tell if it is effective in these patients, but I believe that's what people have been doing across the world as well. Maybe it has some effect, but as you asked, it's difficult to distinguish between one and the other, and I think by and large it may be okay to start empirical treatment based on clinical suspicion rather than do serial CT scans, which may not be always possible in the face of a pandemic like what we are facing now.
So what would be your timeline, considering that you would avoid a CT scan on a regular basis? What would be your timeline that you would consider that, well, this has fibrosis has taken over, or we would treat the patient as a delayed resolution and we would still continue with the steroids, or even steroids are being continued for fibrosis? So how would you change your treatment course based on your clinical pathophysiological assessment, or would you switch over at a particular timeline for a CT scan?
There are no timelines. We go purely on clinical grounds. During the initial phase, many of these patients, although they are hypoxic, the lungs remain compliant. The tidal volumes that you can generate at a modest level of pressure. So that's a reasonable sign that the fibrosis is not yet set in. But after some time, after a week or 2 weeks, you start seeing that the compliance reduces, there is persisting hypoxia, There is poor response to recruitment maneuvers, poor response to PEEP, poor response to proning. In that situation, you suspect that fibrosis may be setting in and you sort of empirically start treatment. That's the way we've been doing it. Generally speaking, there is no fixed timeline, but after a week or two, if your patient still remains on the ventilator, poor compliance, poor response to PEEP, recruitment, proning, you definitely would consider the possibility of fibrosis.
Sir, I'm not talking about the hospitalized patient. I'm talking about those you are sending back home with probably with a concentrator home because of the flooding of because of the overcrowding of the hospital. Sometimes we are sending back patients even with oxygen cylinder or with, and those are the patients basically.
Yeah, I suppose if they are at home, one could do CT scans and get a better idea about how much of lung is involved, what is the extent of fibrosis, if any, and you can target your treatment towards possible fibrosis. CT scans will help definitely in that sort of population, definitely.
Thank you, sir. That was an excellent talk by you, as usual. It's been so illustrative and so very interesting. Thank you, sir.
Thanks a lot. Thank you very much. My pleasure.
Now we move over to our next speaker, who is none other than Dr. Arindam Kaur. We know him as the Secretary of Indian Society of Critical Care Medicine. And he needs no introduction, actually. And we would be going over, he would be speaking on lung fibrosis and imatinib. As you all know, he is the Chief Intensivist now at Sir H.N. Reliance Foundation Hospital and Research Center at Mumbai. He has changed his capital from Kolkata to Mumbai. Now over to Dr. Arindam Kaur. Please.
Good afternoon, all. This is Dr. Arindam Kaur, and welcome you to the World Congress. And thanks the organizers for coming up with this brilliant idea. I hope it would help all of us to fight with the pandemic with more endowment and more knowledge. My topic is pulmonary fibrosis due to COVID and the potential role of antifibrotic therapy with imatinib itself. And this is the basic outline, that little bit of pathophysiology of fibrosis, how it happens, how COVID-19 leads to proliferative lung injury and eventual fibrosis in certain unlucky individuals. Imatinib's mechanism of action, particularly on the basis of its role as an antifibrotic, real-world experience, as well as a little bit of background on how the concept came in laboratory animals, and what could be the future implications and overall verdict. And we all know how the COVID attacks the entire pulmonary epithelium and the immune system, which leads to systemic inflammation and multi-organ damage, but more particularly through the lung injury and leading to ARDS. And this is how it happens. We all know, we have learned through all these 2 days and 3 days, where it involves the entire the ACE2 receptors, the helpers T cells, the cytotoxic T cells, then with an aggravated and sort of amplified immune response, leading to all sort of injuries. But in terms of that, how it leads to pulmonary fibrosis, if you see that there is an inflammation, oxidative stress, and coagulation disturbance that happens due to the tissue response to a lung injury, specifically COVID, and then the resident fibroblast, the bone marrow-derived fibroblast, and epithelial injury. All this leads to excessive deposition and turnover of extracellular matrix, which leads to a pulmonary fibrosis itself. And a lot of other cytokines are involved, right? You can see this is a list of huge number of cytokines, including interleukins, CCLs, and tumor necrosis factor alpha, everything. But two most important cytokines that are involved in pulmonary fibrosis are TGF, that means transforming growth factor beta, and platelet-derived growth factor. And there are a lot of monomers, polymers, variations. Let's not get into that. But please do remember, these are the two most important cytokines involved or in the pathogenesis of fibrosis itself. And this is a basic how the wound healing happens, right? Be it in a skin or be it in a pulmonary matrix itself. That first there is an injury which leads to inflammation, and then eventually repair, which involves apoptosis, phagocytosis, contraction of the wound, reepithelialization, and regeneration. And there is always the fibrosis or scarring happens when there is a disbalance between the pro and anti-inflammatory cytokines, the inflammation or angiostatic chemokines, the myofibroblast proliferation with fibroblast apoptosis, collagen depositions with apoptosis and regeneration. So what we call sometimes when fibrosis happens is called a frustrating wound healing response, right? So what happens, there is an excessive inflammation and production of inflammatory and fibroblast activating cytokines to a breakdown in the anti-inflammatory mechanism and overzealous response of the pro-inflammatory mechanism, right? So it resets the balance, right? And what we can do is that we can try to again restore the balance with targeted therapeutics, right? The pulmonary fibrosis obviously can occur as a serious complications of any viral pneumonia. You can say that, right? We have seen that in SARS-CoV and MERS-CoV, it has led to pulmonary fibrosis in certain individuals, and it has lasted more than 2 years in the follow-up itself. And what COVID-19 is specific is that it can lead to all sort of problems with the cytokine storm, with the thromboembolism, with hyperoxia, with ventilator-induced lung injury. And when there is an aberrant repair mechanism as due to the imbalance between anti and pro-inflammatory cytokines, it leads to impaired repair and pulmonary post-COVID pulmonary fibrosis itself. So the pathophysiology we all know, the pneumonitis, both hypoxia and hyperoxia, particularly this the aberrant interplay between the hypoxia and fibroblast formation and extracellular matrix deposition leads to a frustrated cellular response. Also, hypoxia induces factor 1 alpha, what we specifically called HIF1 alpha. It leads to proliferation and fibrosis, as well as hyperoxia due to therapy leads to the generation of free radical injuries like the superoxide ions or hydrogen peroxide ions, which also contributes to that. So thrombosis, edema, and eventually the fibrosis itself in certain individuals who are having immune dysregulations, particularly the net induced, that means the neutrophil extracellular traps, what we call the activated neutrophils as nets, which is one of the major contributors in this dysregulation. And this is how it happens, right? All the activations of coagulations, formation of microthrombi, then recruitments of the nets, which leads to more anti-inflammatory cytokines getting into this into play and eventually leading to fibrosis itself, right? So this is how it goes. It's a little complex. I would request you to have a little look that how the macrophages, nets, then recruits the fibroblast and myofibroblast. But not everyone gets, because there is a certain factor of genetic or previous disease predisposition, maybe an interaction between the host respiratory microbiota and a major contribution from microvascular thrombosis. At times, we are also contributing to a ventilatory trauma, so we have to be very careful regarding the ventilation strategy, as well as not to overuse oxygen, because hyperoxia can also contribute to that. And this is how, in unfortunate people, the COVID progresses: latent phase, exudative phase, proliferative phase, and the fibrotic phase in the healing is inadequate. And we all have seen that the initial phases, then the organizing phase, then the pneumonitic phase, bronchiectatic and subpleural band. And this is a very classical example of pulmonary post-COVID pulmonary fibrosis, and the hallmark is traction bronchiectasis. So this is what happens. There are certain individuals who have potentially mild restrictive pulmonary function, which may improve or which should improve over time, but sometimes it leads to decompensated persistent chronic lung disease, right, with a moderate to severe alveolar inflammation leading to significant or extensive pulmonary fibrosis, and we do not know that whether in future exposure, chronic exposure to other cytokines might lead to anaplesia and malignancy in these sort of patients. So we have tried, the scientists have tried to use or repurpose certain chemotherapy drugs, particularly diverse possible mechanisms of chemotherapy drugs, anti-cancer drugs might help into the treatment of COVID. So how it works? So some of them alter the ability of the COVID to infect the cells itself. It alters the ability of the host cells to be infected through activation of the interferons. Sometimes it blocks the recruitment of the immune cells to the lungs. Maybe it alters, like anti-VEGF, alters the vascular permeability and sort of blocks the formation of microvascular thrombi. Sometimes it inhibits the cytokine signaling. Some, like etoposide, inhibits the immune cell proliferation, and some of them direct the immune response and control particularly the anti-inflammatory process itself. And these are the huge long list of anti-cancer drugs that are actually being tried in COVID itself, and some of them definitely have proved to be a successful sort of drug to prevent the complications of COVID itself. So we can broadly divide into the drugs which prevents the virus entry, the drugs which prevents virus replication, the drugs which alter the immune response, and some of the drugs which may also prevent the eventual lung fibrosis. So you can see imatinib falls in this category of ABL inhibitors, so which can prevent a viral re-entry, but more action is on prevention of lung fibrosis by modulation of the immune response itself. It's an actually intracellular inhibitor of multiple tyrosine kinases, and it specifically, if you remember, as I told, it inhibits the platelet-derived growth factor, both alpha and beta, and also the c-Abl molecule itself. And specifically, if you see the action against PDGFR by imatinib, actually thought or gave us the thought process that whether it can be repurposed and used to prevent lung fibrosis itself. So it's a potent inhibitor of lung fibroblast or myofibroblast transformation and proliferation, as well as extracellular matrix production through inhibition of PDGF and transforming growth factor beta, right? And it has shown in multiple, I will show you certain slides where it has proved in mice, in transforming mice, that it can prevent bleomycin-induced lung fibrosis, right? And this is, and also the inhibition of c-Abl is also a major process through which imatinib exerts an action on antifibrosis. The dosage is 600 milligram once a day, but it has to be used for prolonged period, 12 to 24 months. This is extrapolated from the experience of idiopathic pulmonary fibrosis. The side effects are GI tract intolerance, rarely myelosuppression, hepatitis, and myalgia. So in cases of intolerance, you might start, you might come down with the dosage of 400 milligram once a day, but in certain cases, it has to be stopped. If you see, this is the experimental pictures from the mice where they were, this is the control picture before and after. This is only imatinib, so it is not causing any harm. This is how the bleomycin causes extensive damage, and this is the bleomycin treated lung along with the mice being treated with lower dose of imatinib with a higher dose of imatinib. So you can pretty clearly see that the imatinib can prevent. So if you compare this one with the control one, you can pretty well see the lung has been almost restored. And these are all the pictures, particularly this is the Ashcroft score of lung injury. You can see that bleomycin along with imatinib, the lung injury is much less, and this is the deposition of collagen. So the difference between no treatment and bleomycin with adequate dosage of imatinib, the difference is pretty evident. And this is a picture from a mixed connective tissue disorder patient followed over almost of 1 year. So you can see there are reticular nodularity in different A. But if you see this picture, right, there is a strong clinical improvement with reduction with the ground glass opacities when the patient was treated with imatinib over 1 year. And there are also improvement in every A. So from the dyspnea of class 4, the patient improved to class 2. The 6-minute walking distance has improved by 50 meters. The DLCO improved. The oxygenation improved by almost 10-12%. And the HRCT findings, as I told, a lot reduction in the ground glass opacities by the imatinib itself. And this is another on the different dosage, and it also clearly proves that this is how the imatinib can prevent experimental lung injury. So we can extrapolate that it might work in vivo. This is the real world experience, right? So almost 120 patients were treated of 120 patients of idiopathic pulmonary fibrosis were treated with imatinib, right? And actually, some of them improved, but what had happened in many, there was acute worsening of idiopathic pulmonary fibrosis, right? So this is a paradox of imatinib. Sometimes imatinib itself can cause a pulmonary fibrosis, and there are certain case reports of imatinib-induced irreversible interstitial lung disease, right? So this is, we have to keep in mind while using it, because there is a mechanism of paradox which we have not been able to fully understand, but maybe a fine minute imbalance of PDGFR in certain individuals can potentially cause this. So we have to be very careful. So that's why, that was the reason that imatinib was not in very much favor compared to the other more popular drugs like pirfenidone, which inhibits TNF alpha, TGF beta, interleukin 1 and 6, and in nintedanib, which also specifically inhibits, like imatinib, PDGFR or TGF beta, along with interleukin 1 and 6, have been effective. These are broad antifibrotic activity regardless of etiology, so it can be extrapolated to be used in COVID-19. And you can see that the studies with both pirfenidone and nintedanib has done pretty well. So this is the list of the total drugs that had been used, particularly nintedanib and pirfenidone. In nintedanib, it inhibits only the interleukin 1 or the interleukin 1 effects along with interleukin 6, along with PDGFR and TGF beta, which prevents the eventual fibrosis, wherein actually pirfenidone has also a potential ability to prevent the acute lung injury at the outset itself. So maybe the usage of pirfenidone can be a little earlier than the nintedanib itself. And the response to treatment and follow-up, what we do, whatever we are using, maybe imatinib, pirfenidone, or nintedanib, the clinical improvement can be done by oxygenation or 6-minute walk test, chest X-ray or HRCT every 3 to 6 months to document the improvement in the ground glass opacities, and the lung function maybe 6 months to 1 year in the forced vital capacity and DLCO. And this is what we recommend, is that PFT at 6 months, if there is improvement in the forced vital capacity or DLCO, less than 10% or decline, we should consider alternative therapy. And if there is improvement, we should continue treatment and in follow-up. So the duration of treatment should be around 12 to 24 months, depending upon the severity of the illness itself. And this is the improvement. If you can see, this is the Impulses trial for nintedanib, where a good dosage of nintedanib continued over a period of 3 to 4 years have shown improvement, but this is with the patient with idiopathic pulmonary fibrosis. So we are just extrapolating, and this is a meta-analysis with pirfenidone, which is showing that it has walked through almost every segment of patients, and in improvement in almost every quarter that we quantify. This is a very interesting slide. I purposefully included that how do we actually measure the ability of a certain drug, whether that is improving the antifibrosis or not. So whether we can treat with the experimental mice, this is the organoids, this is what we call the precision lung cuts, that means the lung tissue has been cut, and this is the 3D in vitro tissues, and this is the newest kid on the block, what we call lung on the chip itself. A lot many in the histopathological process there has been progress, and this has helped us to come up with certain drugs right from the bench to the bedside itself. So what next? These are the other drugs that have been, besides nintedanib and pirfenidone, those are being tried, particularly the JNK and autotaxin inhibitors or AT2R. Maybe in near future, we'll come up with certain of those drugs which are being tested in different trials in different phases, may give us a better antifibrotic therapy itself. But you have to also remember that this lot many antifibrotic therapies are repurposed, and the chemotherapy drugs or anti-cancer drugs, and they are not devoid of side effects. Some of the side effects can be very difficult to treat, or very, and at times you have to stop the therapy itself, right? Particularly the latent infection, the coagulation process, autoimmune dysfunction, hepatotoxicity, immune suppression, hypertension. So you have to be very careful while you are using antifibrotic drug, the potential, the side effects of these drugs that can hamper the overall benefit of the patient itself. And this is a very another interesting slide, that why particularly the pulmonologists are not very keen to use, what is the logic behind of not using too much of antifibrotic drugs. And if you see, most of them are based on the perception of the pulmonologist. So a better understanding of the disease process, a better understanding how the drugs work, their effects and side effects actually can help to make you decide that which patient needs what particular antifibrotic for whatever duration, and how to monitor those patients to know whether they are being effective, the drugs are being effective, and the patient is getting better. So the key messages are COVID-19 leads to wide spectrum of respiratory diseases, and there could be high incidence of ARDS, and some of them can progress to pulmonary fibrosis. The risk factors for severe COVID are shared with IPF, suggesting that certain group of patients will be at increased risk of having a severe COVID-19. The burden of fibrotic lung disease following COVID is likely to be high, and given the scale of pandemic, the global burden of fibrotic lung disease will probably increase considerably. There is a therapeutic rationale for use of licensed antifibrotic therapy in acute exacerbation of IPF, including those triggered by viral infection. So you can pretty well use it in certain cases. Available antifibrotic therapies have broad antifibrotic activity regardless of etiology, and these drugs might have a role in attenuating pro-fibrotic pathways. Novel antifibrotic strategies have a range of antivirals and epithelial protective effects in certain models. Previous corona outbreaks have been associated with substantial post-viral fibrosis and physiological impairment. So we need to closely follow up patients who are suffering from COVID-19. And there is an urgent need for effective therapies. Maybe pirfenidone, nintedanib, and to some extent imatinib can suffice at this time, but we need much more clearer and precise answers for specific antifibrotic therapy in post-corona pulmonary fibrosis. Thank you.
That was an excellent talk. Is Dr. Arindam Kaur there? Is he there?
No, ma'am.
No. Is Dr. Anup Kumar, is he still available? I don't think. So we have come to the end of this session, and that was an excellent talk by all the speakers. Now I hand over the platform to our organizers. Thank you.
Good afternoon, everyone. Here, now we start the debate. To chair this session, I would like to request Dr. Dhireen Gupta, Deputy Director, PICU, Pediatric Pulmonology, Sir Gangaram Hospital, New Delhi. I request Sir to please introduce the speakers for the debate.
Sorry, good evening, everybody. And we know that, COVID is very important topic and the whole conference is revolving around COVID. So now we are going to discuss where these patients, especially pediatric patients, should be admitted and managed. Is it PICU only or they can be managed in ward? So to talk about the pro topic, I'm going to introduce a very young and enthusiastic speaker, that is Uma Shankar. She is additional professor at AIMS, and it is just a small introduction for her, but she's not only a friend to me, she's very enthusiastic researcher, and she has got a number of papers at her name. And the second speaker is going to be another friend, Dr. Arun Bansal. He is again Professor Pediatric Emergency and Intensive Care at PGI Chandigarh. And if I start introducing him, that the whole debate will finish and I'll consume up whole of the time. So let's begin with the debate, and I invite Dr. Uma Shankar to present. Sound is not there. Can we have? It's not audible.
Sound. Farhan, share please once again. Sound is not coming.
I think you need to share with the system, only then sound will come.
Good afternoon and welcome to this interesting debate on should COVID hospitalized children be managed in the ICU or not. I would be speaking for this topic, and Dr. Arun Bansal would be speaking against the topic. General observations during the recent and ongoing COVID-19 pandemic suggest that the disease has had a relatively milder course in children. This is the observation that we all have had. And but however, the reports and the systematic reviews that have reviewed the actual data, they have shown that about half of these children have moderate to severe disease. For example, this systematic review showed that 50% had either moderate, severe, or critical illness. So it is against the notion that most children have only mild disease. If you can imagine that if 50% have severe disease, then it is a thing. It is an issue to be really concerned about. We have our own data from 12 centers across the country of 402 children. And in these children, we found that almost 10% had moderate to severe cases. Again, highlighting the fact that children also have severe disease and how important it is to identify these children and manage them. And almost 13 died, and 13 children died, which was almost 3.2% of the total population. So the deaths reported vary between 1 to 5%. So again, 5% of these children are also have also had a bad outcome in the form of death or severe morbidity. And while asymptomatic children tested for other indications or children suffering from mild disease may be managed on domiciliary basis, but we have to ensure adequate isolation measures at home, which is often very difficult. However, we also have seen that almost half of these patients need hospitalization. So this again reiterates the fact that we do not want to miss out this 50% of children who are prone to have severe, moderate to severe disease and who will benefit from admission to the ICU. Keeping these facts in mind, the Delhi government, as I would like to highlight from this clip, that before the third wave started, because we know that in the first two waves, adults were infected and then vaccinations were available. The third wave, everyone, we were all concerned that children will be affected the most because they are the most vulnerable population. There was no vaccination available in our country till September 30th when the ICMR actually announced that we have a vaccination for younger children also. So younger children were much more vulnerable, even though vaccination was available for more than 12 years, for less than 12 years, it was not the case. So this group was very much vulnerable, and they were vulnerable to severe COVID infection. Therefore, you can see that the Delhi government was preparing preemptively. Not only the Delhi government, the centers all across the country were in preparation of the third wave, and we had a lot of training programs. We conducted programs for almost 300-400 nurses as to how to care for these children, and we were prepared to convert the trauma center and our facilities to ICU kind of a setup to take care of these children. So this was all preemptive, but it was in preparation with the fact that these children may develop very severe disease and may require ICU admission. I'll also give an example of a case, a 2-year-old child who presented with a history of cough, cold and fever for 3 days at the time of the pandemic peak, when the pandemic was at its peak. The parents, of course, were infected. All of them had mild symptoms to begin with. So they were advised home and isolation and sent home. However, the next day, the child, within 24 hours, the child presented with ARDS, multi-organ failure, admitted to the ICU and had a severe course of illness. So this case again highlights the fact that how vulnerable children are. Children, we know that they have limited physiologic reserve. They decompensate earlier than adults. Neonates and young infants have immature lungs and lower lung volumes, and the alveolar development continues till 3 years of age. So this population again is the most vulnerable, and they have very limited pulmonary reserves, very limited cardiovascular reserve, and high demand for oxygen and glucose because they're very active and they require a lot of metabolic fuel for their growth and for their daily activities. Therefore, all these factors make children very prone to critical illness as compared to adults, and they are best managed in the ICU. If they have mild to moderate disease, they should be admitted to the ICU and they should be monitored so that we can, we can prevent this 50% who are likely to have severe infection from having bad outcomes. And even though we say that mild illness, the children should be monitored at home, but but we all know that it is difficult to follow precautions. A child cannot keep a mask on, a child cannot follow hand hygiene. So these are the practical difficulties that we faced as pediatricians during the pandemic, and to make them have food, to give them their nutrition. So all these factors are very unique to children. If a child is not having food, for example, and parents are also unwell, then it makes the child much more prone to, decompensation than an adult. So this child, if it was monitored, if he or she was monitored in the ICU, at least we would know the blood sugars and we could we could give them fluids and keep them hydrated. So these are the advantages of admitting these children and following them up or monitoring them in the ICU. And once infected, as I already highlighted, it's difficult to monitor at home. And of course, we heard that they are super spreaders. So if you keep them at home, they are a source of infection for vulnerable elderly population. So these are the practical difficulties we face, and we can be much more assured that a child may have a good outcome if the child is admitted and observed in the ICU. So to summarize, because of the limited physiologic reserve, almost 50% having moderate to severe illness and requiring close monitoring, and almost less than 5%, even though it's less than 5%, still 5% of them are dying, and issue with the availability of vaccine. All these issues make it make us think that we should admit these children in the ICU, and we should monitor them very closely so that we can pick them up before they exhaust their physiologic reserves and they decompensate and have bad outcomes. So thank you. With this, I end the pro debate, and now.
So thank you, Dr. Juma. Now I call Dr. Arun Bansal, and after a very practical presentation, and I'll invite Dr. Bansal to put up his version of the topic.
Thank you, Dr. Juma. You tried really hard, but I know I must thank the organizers for being lenient with me and giving me the part of the debate in which there is no debate. So, and I think you made my job easier, and you had almost agreed that all children don't require ICU care, but we'll go through some of the evidence, and I'll try to focus on what is the current incidence of the pediatric COVID in the world and also in India, whether pediatric COVID is severe or mostly mild or asymptomatic. Then what is the scenario in children with comorbidities? What does the Indian data say, and what are the various guidelines, and then we'll come to the final recommendations. So we all know that the burden of COVID-19 in children is not much, but this is the UNICEF data as of 20th October from 105 countries, in which 99 million cases were there. And out of, there were around 14% children were involved in were infected who were less than 20-year-old. So in this age group of less than 20 year, very few children were involved as compared to the adults who were more sicker or had the COVID-19 infection. Similarly, amongst the deaths, as per the world data, out of the data available from 82 countries, there were 3 million deaths. Of that, only 10,600 deaths have occurred in children. That is almost only 0.5%. And also majority of deaths were in the adolescents or in the older children, not in the younger children. They were pretty much safe from the severe illness. And if we go to the data from the lower and middle income countries, data from 27 countries, total of 13 million COVID positive cases, and in pediatrics only 11%. That is only 1.39 million cases. And again, majority were adolescents. And deaths in the low middle income countries, again, very less deaths, only 1,700 deaths from 17 countries data, including in many low middle income countries, out of the total around 211,000 deaths. And majority, again, deaths were more in the older children. Then coming to what is the Indian data is saying. If we see again here in this, the ICMR data as of 20th October, which says that out of around only 11 or 12% cases were involving the pediatric patients, and a majority of the infections were seen in the adults. And what is our own data from my institute at PGI is saying that out of around, we had seen around 7,200 cases of COVID positive were admitted, and only 8.2, that is 592 cases were pediatric cases with COVID positive. So the infection rate is already very less in them, as we see. And the deaths were also very minimal in the pediatrics. So now amongst this, we have to see that whether they get the severe infection or not. So this is from where it started, the Chinese. So they had seen that almost all the cases of these around 50 odd cases were either asymptomatic, mild or moderate. Only 2 cases out of 50 were severe infection or severe COVID requiring ICU care. Similarly, again, if you see, this is the data from Germany. Around 2,500 tests were done in the pediatric patients. Only 36 patients were positive, that is only 1.4, and almost all, in fact, all patients were either asymptomatic or mild and did not require any ICU care. This is from the UAE, 111 children. Again, all majority were asymptomatic or mild. So all were asymptomatic or mild, and none required intensive care, ICU care in them, and all survived. Another data from Turkey showing of 422 children, of which 78 turned out to be COVID positive. Mild, moderate, or asymptomatic were majority. Only around 1.2 was severe, and there were no critical case in them, and none of the children died in their data. Again, none of them required an ICU care also in this. So no patient was admitted to the ICU in this group. Then this was a large data from the US, from the New York and Utah cities, around 1,200 children. And if we divide it into various age groups, majority, more than half, were asymptomatic. But as we move towards the age, and we go from the adolescent to older, the asymptomatic cases starts dropping. So this again shows that the pediatric patients are lesser, are majorly asymptomatic than the adults. This is the data from the Indonesian registry. Again, they had around 37,000 pediatric cases and only 175 deaths with case fatality rate of 0.46. And majority of the children who were critical or died were either having respiratory failure or encephalitis, or they had a shock. So only those children who fall into those category need an ICU care. This is a large meta-analysis of 19 studies of around 3,000 children with COVID-19, and almost 80% had mild symptom and only 4% were critically ill requiring ICU care. This is again their comparison between the COVID and the non-COVID children from requiring the ICU care. And if we see here, the severe ARDS of 9 children, 7 were non-COVID and only 2 children with COVID developed severe ARDS. Rest have mild or moderate only, and the mortality was also not very high. This was again a multicentric data from Spain. And this is a large paper published in large data from 51 ICU centers, 12 countries, including India there, and published by Utpal Balala in Critical Care Medicine. And again, if we see less than 50% of the children out of 874 required the ICU care, and majorly were non-ICU, and they had a very good outcome in them. And the children who required ICU care were mainly either having the MISC or the seizure disorder, or they were older children. So only these children were requiring ICU care. Now, coming on to this, is it only relevant to the normal population of the children or children with comorbidities? We need to see that, do they need any special attention? This is the data from Iran of the children with the cancer, in which there were 17 patients with malignancies, either leukemia or the brain tumor. And out of 17, almost all were mild and only 3 were asymptomatic. 3 children died, but the mild, they concluded that the mild COVID cases had no relation with the severity of, even if they turned to be COVID positive. Now, again, Turkish data on the inborn errors of immunity, if they had immunological deficiencies. Out of the 371 children who were immunodeficient, 32 children of there became COVID positive, and 22 remained asymptomatic, and they had all kind of immunodeficiencies, phagocyte deficiencies, combined immunodeficiencies, and A gamma globulinemia, and all were there. So again, they were either asymptomatic, there were no deaths, and very minimal, very or less than half of the children required hospitalization. Similarly, children with COVID, with kidney disease from Israel, 197 children with renal failure, chronic renal failure, 37 of them remained asymptomatic and only 3 required hospitalization. Rest, all of them were mild. And their COVID positivity in these children did not require any modification of treatment. Now, children with heart disease, do they behave differently? 42 patients, again, major were asymptomatic or mild, and only 6 required admissions and none of them died. So what does the Indian data show in this? This is the paper from our unit in which we have seen 31 children, 6 had comorbidities, 58% were asymptomatic, only 1 was critical, and only 3 required PICU admission or invasive ventilation, and out of 31, only 1 died. So rest all were managed in the COVID ward only. This is the paper which Dr. Juma has published from their unit, but it's a multicentric data. If we see again, the asymptomatic and mild were major. Only 9% or 10% were having moderate to severe disease requiring ICU care. And out of that, only 14 children or 6% required ventilation and 11% required inotropic support in them. So having this evidence, what do the various guidelines say about the management? Where do these children should be managed? This is again a very good paper in pediatric emergency care, a review article and the guidelines from the Canadian and the US group. Again, they have said that if they are asymptomatic, they should be discharged home or managed at home. If they are mild, they again should be discharged home. If they are moderate, you can admit them in the hospital, but do not require ICU care. Only if they are severe or critical, they need admission in the ICU or in the hospital or in the ICU care. This is the Indian Academy of Pediatric Guidelines published in June this year. Again, mild cases have to be managed at home or OPD basis. Moderate cases, again, they can be managed only in a COVID ward. They don't need ICU care. Only if they are severe or critical, they need ICU or HDU care. This is the Government of India Ministry of Health guideline, which say that asymptomatics need to be managed at home. Mild cases need to be managed at home. And if they are moderately ill, they need to be admitted in COVID-19 hospital, and only the severe ones need ICU or HDU care. So these are the various guidelines which again say that only severe and critical cases need ICU management, and protocolized and algorithmic management is important. So the final answer is that no, all children do not need hospitalized ICU care for these COVID patients. So thank you so much. We can take up the questions with me and Juma be there. So thank you all.
Yeah. Thank you, Dr. Arun, Dr. Juma, for lucid presentations, and all were evidence-based. And Dr. Neera, you can look at the chat box if there is any question. I didn't see any questions in the chat box. So, but I'm, I'm on mobile, so it's difficult. So if you can find any question, you can ask the debaters. And I think there are no questions. And I feel that, this topic was not very appropriate for the debate. The reason, because I agree with the second speaker more than the first one, though both presented with their data, and Dr. Juma also presented the robust data from their unit. But in general, pediatric intensive care units were almost vacant during COVID. But Dr. Juma Shankar data will be more appropriate when we talk about MISC. Means that is a part and parcel of the COVID, and we all know that third wave, there was there was too much talk in the country about the third wave and pediatric involvement. So we should be ready for the third wave, especially for the MISC. Presently, we are looking at the dengue and the number of ICU beds being occupied by the dengue. That open up the Pandora box, saying that our system is insufficient to deal with sick patients. So what we need more beds for the sick patient. we assume that if third wave comes, which is probably unlikely, but we don't know, this virus is very unpredictable. And if it strikes at the pediatric patients as it has struck the adult patient, and especially following COVID, there's a huge surge of MISC, then we'll be requiring many beds, intensive care beds, which we are lacking. So it's a need of an hour. If we take, take home message from the debates, both presented well, that whether it required ICU in the past, didn't require ICU in the past, but we should revamp our system and we should make the beds available in the future. If any time the third wave comes, or especially if the same number of patients as comparable to dengue, there is a surge of MISA. Thank you very much, and I think Dr. Arun and Juma are there. If they want to comment in the last, they're allowed to take one comment each.
Oh, I think Dr. Dhiren, good afternoon and good welcome everybody. But I don't think there is anything left. You have very well summarized it. So thank you so much.
Okay, thank you. Thank you. Dr. Juma. I think she has left. So thank you, Mr. Neeraj. Thank you,
no,
Dr.
Dr. Juma is there.
Yeah. Sir, as you rightly said that this was not an appropriate topic, but yes, it was interesting to fight for something which we know, to speak for something which we ourselves, can't believe in. So it was more challenging. And yes, MISC, it is part of whatever we spoke about the moderate to severe cases. So I did not highlight separately about MISC, but definitely they are the patients whom we have seen that all of them require ICU care. So yes, that population would be all have to be monitored. Yeah.
Thank you very much, and we conclude our debate.
Thank you everybody.
Good afternoon, everybody. Now I would like to start panel discussion. Here I introduce our chairperson, Dr. Dinesh Mathur, Professor Head, Department of Skin and STD, JNU Medical College and Hospital, Jaipur, former Pro Vice Chancellor. So I would like to request Dr. Dinesh sir to introduce our panelists.
Ma'am is not able to log in, so I think we must continue.
Well, greetings from the largest democracy of the globe, and greetings from the doctors and the dermatologists who deal with the largest organ of the human body, that is skin, and we are dermatologists. And today we will be talking about the dermatological manifestations or relation of dermatology with COVID-19, the world, the menace which we have seen throughout the world. So, and we have got two most prominent doctors, dermatologists with us, Dr. Murali Dhar Rajgopalan, who is from Chennai, and Dr. Resham Vasani, who is from Mumbai. Dr. Murali Dhar Rajgopalan, he is working for Apollo Hospital, and he has got more than 34 years of teaching experience, and he has got various special interests in, say, immunodermatology, psoriasis. He's known as a man of biologics. He has got the interest in bullous diseases, pediatric dermatology, and he has got more than 44 international and publications and 8 orations and 1 national oration, and more than 250 invited lectures as faculty. He is a member of Indo-French Working Group on IVIG in drug reactions and Marcus Bolan Visiting Lecture on Vasculitis, Rutgers University, New York. He is IPC Counselor for India in 2006 and member Board of Director of International Society of Atopic Dermatitis. He is reviewer of more than 16 journals there and lot many other things to his credit. We have got another dermatologist with us, Dr. Resham Vasani. She did her post-graduation in dermatology. She has got a unique qualification of DNB as well as FCPS and DDB both. So she is a consultant dermatologist of Bhujanani Clinic, Mumbai, and a clinical research associate of BJ Wadia Hospital for Children. So Dr. Resham has got the DAS Awards of Excellence in Dermatology. She is assistant editor of IGDVL, IGDD, IADVL Handbook of Pediatric Dermatology. She is an editorial board of IDOJ and IJPD, and she is a member of IADVL Academy from 2016 to 2017. She is a winner of National Amala MD Gold Medal in 2019. She also did the IADVL Training Fellowship in Dermatopathology, and she has got 48 national and 9 international publications and 14 chapters to her credit. And she has got many scholarships also to her credit, that is ISA, Munich, ICD, Delhi, and so welcome Dr. Murali Rajgopalan and Dr. Resham Vasani. And with this introduction, Murali, can I ask you, do their skin manifestations occur in the COVID-19? And if yes, what is the pathophysiology?
Thank you very much, sir. Pleasure to be here. Direct answer would be yes. There are a variety of skin manifestations that occur, all of which have been documented. The issue over here is that if you ask me if there is a specific skin manifestation which differentiates COVID from other diseases, the answer would be no. The reason for that is in the pathophysiology. The pathophysiology of COVID infection involves invoking a cytokine storm, And the cytokine storm involves the recruitment of CD4 and CD8 cells. Apart from that, once a cytokine storm takes place, there is also a combination of three major events. One is a vasculitis, second is a vasculopathy, and disturbance in the coagulation profile of the patient. The combination of all these three can be seen in biopsies of skin lesions seen in COVID, which Dr. Resham will show. So this specific triad of combinations is very important. The other point I would like to emphasize over here is that there is also direct infection of crucial cells by the COVID-19 virus. One is direct infection of the endothelium, which produces endotheliitis, and that seems to trigger off the coagulation cascade and the vasculopathy. It also triggers off vasculitis to a large extent. Second, the COVID-19 virus can also be demonstrated in altered keratinocytes. The virus has the capacity to alter the shape and the morphology and even the functioning of the keratinocytes. So we will talk a little bit more in detail about this, but the hallmark of a skin biopsy in COVID skin lesions would be tufts of Langerhans cells, which are present in the skin lesions of COVID. So the short answer to the question that you put to me, sir, would be that yes, skin lesions do occur. The manifestations are varied and they depend upon the type of pathophysiology that has been elicited or is prominent in that particular patient. There could probably be a genetic variation in the type of skin lesions that become prominent in different populations. And you can establish a direct link, a causal link between the COVID-19 virus and the skin manifestation. So though the skin manifestation is not specific, there is no single skin marker. The point is that once the skin manifestations occur, we know that they are due to COVID and not some kind of a bystander effect that is happening.
We're talking about Langerhans cells. They are as such the antigen presenting cells.
Yes,
would you like to give some more examples in the sense? Are they very specifically being described in this in the literature, Langerhans cells, or
yes,
the local skin system is working for that?
Yes, sir. The Langerhans cells are the antigen presenting cells, and COVID-19 we have autoimmune phenomena which take place, and the Langerhans cells are recruited for that, and they present the antigen to various parts or limbs of the immune system. And we shouldn't forget that the keratinocyte itself is one major limb of the immune system, and the Langerhans cells presents the virus to the immune system in the keratinocyte. So there are tufts of these Langerhans cells which present the virus. So in the skin biopsy samples of, let us say, an exanthem, which Dr. Resham will show, you will find tufts of Langerhans cells in patients with COVID.
Great. So let me go to Dr. Resham. Resham Vasani, Resham, would you like to show what are the kinds of dermatological manifestations you have seen? Let me. Can you make it on full, please?
Yes, sir. Fine.
Fine.
Just 1 minute. Oh, sorry, it's yeah. So is it visible now?
Yes.
Yes.
Thank you so much, sir, for the kind invitation. So I'll be presenting a few cases of dermatological manifestations of COVID-19. So if we see the cutaneous manifestations of COVID-19, first let's discuss the ones which are caused by the virus itself. So they can be divided.
Bit loud, please.
Yes, sir. Yes, sir. So they can be divided as whether they are inflammatory or vasculopathic. The inflammatory lesions can be divided further as a group of confluent erythematous maculopapular or morbilliform lesions, urticarial lesions, vesicular or varicella-like lesions. And among the vasculopathic manifestations, we have pseudochilblains, livedo reticularis or livedo racemosa, vasculitis or purpuric lesions. So in that group of confluent erythematous lesions, the lesions can be morbilliform, that means measles-like. There can be PR-like or pityriasis rosea-like lesions. There can be erythema multiforme-like lesions, erythema elevatum diutinum-like lesions, or perifollicular lesions. So this is an example of a morbilliform eruption where we can see that it starts off as discrete macular and slightly elevated papular lesions, and then there is a tendency towards coalescence. So this particular presentation is associated with an intermediate severity of COVID-19. Then this is an erythema multiforme-like eruption, which is characterized by the presence of target lesions. So here we can appreciate the targets very well when we see that there is a central dusky erythema followed by a middle pale ring of edema, and then there is a peripheral flare of erythema. So this presentation usually occurs on the acral areas, but as we can see in the previous picture, the lesions were generalized and they were tending towards confluence. So this kind of cases, one needs to rule out any drug-induced cause before it can be labeled because of the virus. Then there are pityriasis rosea-like eruptions, which starts off as a erythematous papule, which becomes annular. There is central clearing and there is peripheral colorate scale, which is very classically present. And this patient was seen post-asymptomatic COVID-19 a week later. Then there can be erythema elevatum diutinum-like lesions, where the lesions are mainly erythematous papular lesions on the dorsa of the hands. Then there can be perifollicular lesions. So what we need to know about the maculopapular eruptions are that usually they occur after the symptoms of COVID. It can occur because of the hematogenous spreading of the virus through the cutaneous vascular system, as well as the immunological reaction to the viral particles. There is usually a generalized, symmetrical, and kind of a centrifugal progression. Can be associated with pruritus. On histopathology, vascular damage is something that's very prominently seen, and this is associated with intermediate severity of COVID-19. Going on to the urticarial eruptions, here the urticarial eruption will usually not be responsive to the conventional doses of antihistamines. The eruption is going to occur either prior or it can occur with the symptoms of COVID-19. Sometimes there may not be any symptoms of COVID-19, but a CBC may show the presence of lymphopenia. If we see clustering of urticarial eruptions in a family, that is something that should give us a clue that it is COVID-associated urticaria. Another presentation is urticarial vasculitis, where the lesions of urticaria will persist beyond 24 hours. The symptoms will be pain and burning in addition to itching, and there can be associated edema of the extremities as well as systemic symptoms. So in such cases, a biopsy is very helpful to confirm the diagnosis, which would show the presence of vasculitis involving the small vessels of the superficial and mid-dermis. And the patient, of course, in addition to the antihistamine, would need an anti-neutrophilic agent like, say, dapsone or colchicine. And of course, in many cases, these presentations, they resolve once the COVID-19 subsides. So what we need to know about urticaria and COVID-19 is that the incidence is usually 19%. There can be acral generalized presentations as well. They can occur with or without angioedema. The lesions can occur before or after COVID symptoms. And this is maybe reflecting the cutaneous expression of the ACE2 by direct stimulation of the mast cell degranulation and complement activation. On biopsy, we do see vacuolar interface dermatitis with necrotic keratinocytes, and this presentation is also associated with intermediate severity of COVID. Now, vesicular eruptions have been reported which look like varicella, but they differ from varicella by the fact that they are not in varying stages of evolution like we see in varicella, and the lesions can be characteristically very itchy. This may happen because of a reactivation of the herpes viruses and not directly because of COVID. Then going on to vasculopathic manifestations, pseudochilblains is a presentation that we see in a younger age group, and this is typically going to happen in the late stages of COVID. It presents as erythematous, violaceous or purpuric patches and swellings with involvement of the periungual and the subungual skin. This not only involves the toes but also can involve the fingers. And most of the times the PCR is negative, possibly because this presentation is late into COVID. Also, sometimes the antibodies come out to be negative. This can happen because of a heightened response of interferons. Then going on to livedo reticularis. This is a regular lace-like network of non-fixed dusky patches forming complete rings surrounding a pale center. So this has been attributable to the vasodilatation caused by the SARS-CoV-2 infection of the endothelial cells or the vessel-associated smooth muscle cells. This has been associated with intermediate severity of COVID-19, while livedo racemosa, which is non-symmetric, localized and unilateral with an irregular network of broken rings, is associated with a greater severity of COVID-19. Then there are purpuric eruptions which can suggest vasculitis. Also, there have been other representations like palmoplantar dysesthesia, where the patient experiences intense pain and burning sensation over the acral areas, and this resolves with the symptoms of COVID, and that gives rise to acral peeling. So this is a table which shows us the severity of COVID-19 and its correlation with the dermatological manifestations. So here we see that pernio is associated with lower severity of COVID-19 and sometimes even asymptomatic COVID. Vesicular, urticarial, maculopapillar eruptions, they are associated with intermediate severity, which may not require hospitalization. While vasculitic lesions, livedo racemosa, retiform purpura, these are the skin manifestations which we usually see in the ICU setting in severe COVID. Going on to oral manifestations, they have been very non-specific, just like erythema over the tongue, erythema over the hard palate, few ulcerations at the angle of the mouth. Whether these are directly due to COVID or because of reactivation of other viruses or drugs or confinement is something that is unclear, but these have been reported in patients having active COVID. There are nail manifestations reported like the transverse red half moon nail sign. Then there are Bose lines and Mees lines which have been reported. Then herpes reactivation in the form of herpes orolabialis, herpes simplex, or even herpes genitalis that has been reported during active COVID. And the reactivation is possibly in relation to the lymphopenia. There can be multiple cases of reactivation of herpes zoster that we encounter, which can be complicated. Like in this patient, there was Ramsay-Hunt syndrome. Even pediatric herpes zoster is something that we more commonly seen with COVID. Then this is another intriguing syndrome, that is MIS-C, that is multi-system inflammatory syndrome in children, which looks like Kawasaki. There is non-purulent conjunctivitis, polymorphic rash, mucosal changes with swollen extremities. The way it differentiates from the regular Kawasaki that we know is that there is a significant older age of onset. It is more frequent with gastrointestinal and respiratory manifestations. Coronary involvement is more in Kawasaki versus Kawa COVID, and COVID positivity is seen only in 75.5% cases, but the risk of ICU admission is definitely higher in Kawa COVID. Then we also see relapses or new onset autoimmune disorders like alopecia areata. Like in this case, a relapse of alopecia areata occurred post-acute COVID with appearance of Mees lines on the nails. Then this was a patient who presented with oral lichen planus bullous presentation for the first time again in the post-COVID phase. This is urticaria, which first presented and it was very difficult to control with the regular doses of antihistamines. This was again post-COVID. Thrombocytopenia can occur post-COVID and can manifest with purpura and hemorrhagic blisters in the mouth. Further, these kind of ecchymotic patches can be a manifestation of post-COVID thrombocytopenia. Also, we are aware that there can be prothrombotic phenomena which are induced by COVID because of the endothelial dysfunction which remains persistent even post the acute symptoms, and a prolonged vasculitis. So this is one of the manifestations where we can see dry gangrene. This was seen in a patient 2 months post-COVID, and there was associated thrombosis on Doppler. This was another patient who presented with painful discoloration of the fingers with the Doppler showing thrombosis. This was disseminated intravascular coagulation post 2 months of COVID, and this was post-COVID DIC hence. Also, now we come across post-COVID sequelae, which are expected sequelae of a post-critical illness like telogen effluvium or Bose lines, as well as there are many cases where we just see acral peeling, which can be mild or severe as in this case. Telogen effluvium is a very common presentation, and when that occurs en masse, one can present it with plica polonica. Then mucormycosis can present itself as a palatal ulceration, as we can see in this case, where a smear will be very diagnostic. Or it could be a swelling on one side of the face with associated blood-stained nasal discharge and induration pain. So adverse reactions have also been reported post-COVID-19 vaccination, which includes morbilliform reactions, urticaria, chilblains, pityriasis rosea. This is the typical COVID arm, which is a localized area of swelling and induration, which can happen following the second dose as well and much earlier. But it is something that is self-limiting and can be given conservative treatment. Reactivation or inflammation at the site of fillers is something that is seen, which necessitates the high-dose intralesional steroids with hyaluronidase to dissolve the hyaluronic acid filler. Vaccine-induced thrombocytopenia has been reported, which manifests as petechiae. Erythema multiforme can be seen post-vaccination, and vaccine-induced vasculitis, small vessel vasculitis, has been reported post-Covaxin. So these are things which, as dermatologists, we have been seeing, but still it's an evolving science. Skin lesions can occur before or after COVID-19, and possibly they can also help in gradation of severity. So that was my 2 cents. Thank you very much.
Great. So all kind of manifestations, you have got a beautiful collection of that, and we can see that right from rash to vasculitis, vasculopathy, and even hair loss, telogen effluvium, and plica polonica or plica neuropathica, all kind of manifestations have been seen. Dr. Murli, would you like to comment over in the final, so that before we finish, would you like to speak anything?
Yeah, I have only 2 points to make. Excellent collection of slides, which should be an eye-opener for all practitioners. If you really want to sum up the whole thing, then we go back to my first statement. It is a combination of features of vasculitis, vasculopathy, and coagulopathy. Interestingly, the coagulopathy could be hemorrhagic or non-hemorrhagic, which is why you have such a wide variation of lesions in COVID and skin. One point I would definitely like to make and re-emphasize is that the skin lesions can occur even 1 or 2 months after the acute COVID infection has passed. So even during the long COVID syndrome, the end of which we really actually don't know, you can get skin manifestations. The last point I would like to make is that there was a case report published in British Medical Journal case reports, where they reported small vessel vasculitis. And this patient was post-COVID, but did not have active COVID in the nasopharyngeal RT-PCR. However, antibodies were very high. But in order to test the hypothesis that the endothelial cells get activated in COVID and produce vasculitis, the authors looked for RT-PCR in the skin samples, and they found that COVID was demonstrable in the mRNA was demonstrable even in the keratinocytes post-COVID in the vasculitic lesions, which served as a very clear linkage or clear manifestation or sign that these skin signs are actually specific for COVID. But the thing is, these are not mere clinical skin signs, they are clinico-pathologic skin signs. So if you look at the pathology, you're going to see vasculitis, thrombosis, coagulopathy, and you have to do an RT-PCR. Without that, you cannot say that this is not due to COVID. I will end by introducing the Trojan horse concept. The Trojan horse, as we all know, was in mythology. A lot of soldiers were hidden inside a wooden horse and taken inside the city of Troy. Similarly, along with as COVID infects the individual and there is viremia, the macrophages take the COVID virus and present them to the keratinocytes. And once the mRNA gets into the keratinocytes get remolded and their antigenic presentation changes. So this makes, so when the inflammatory reaction and the immune cascade starts, the keratinocytes are susceptible to damage. It does not mean that the keratinocytes are infective because they only have the mRNA, but the structure of the keratinocyte is made more antigenic and susceptible to damage. And that is why you have very extensive hemorrhagic and necrotic skin lesions happening in COVID. So these are exciting concepts of COVID and skin, which we need to work on and study further. Thank you very much, sir, for
Thank you. And this was the presentation from the doctors or the dermatologists who are dealing with the largest organ of the body, and that we have presented that there are so many large and different variety of manifestations of the dermatology in the COVID. Thank you very much once again, and over to the organizers. Thanks a lot.
So I would like to conclude the conference. Thank you, respected senior, for sharing your knowledge and experiences on various topics. Thank you everyone for attending the session. Have a great evening.